Alrighty. Hi, everybody. This is PNR 203 Exam 1 Review, and I have Ms. Nicola Adams with me today. And we're going to talk about chapters 2, 3, 4, and 5. So get your thinking caps on, and here we go. Okie dokie. Let's see, it's right there. So here we go. Again, like I said, it's a lot of chapters, 2, 3, 4, and 5. So, the best way to handle any kind of exam is to be prepared. Okay, so that's the purpose of taking this time and doing this little review so that everybody can start thinking. And maybe you forgot about chapter 2. It could be, right? All right, so let's go ahead and get started. Remember in chapter 2, we talked about puberty and how it was like a transitional stage between childhood and sexual maturity. So what it does, it involves the entire body and the psyche. Okay. Oh, hello, Alan. How are you? Okay, it also the reproductive system matures and becomes capable of reproduction. And then, of course, during this time, secondary sex characteristics will appear. So, and this time actually ends when mature sperms now are formed in the males and the menstrual cycles become regular in females. Hi, Alan. This is Professor Dunham.
Hi,
Hi, how are you?
I'm good. Thank you.
Good, good.
Sorry
Welcome.
I was so much
I'm glad
late.
you can join us. This is chapter 2 that I'm starting out with because we
Okay.
have chapter 2, 3, 4, and 5.
Yes.
Okay. And then I'll be sharing my screen so you can see the information, make your little notes. And then I'll ask you some questions, okay?
Okay.
Okay, everybody. So again, chapter 2 was on, remember, if you can remember, the testosterone, male hormone. These are when the little boys increase their muscle mass and strength. They promote growth of long bones. And the big thing here is enhances production of red blood cells. Okay. And produces enlargement of vocal cords. This is, it could be a good little question for you on an exam. What happens during the time of young men with testosterone? Yeah, the vocal cords change and affects the body hair distribution. So, those are things that you need to just kind of put in your back of your mind. Remember, under here, I put this is right out of your book on the female reproductive system. And what I always like to point out is just the landmarks, because this is what you hear when we're discussing things. And as you probably didn't have in your lecture, but the mons pubis up here, which covers the symphysis pubis, and then you have the urethra, and then the vagina, which it's a passageway for the baby. The labia majora, labia minor. These are all very important because basically they keep bacteria from entering into the vagina. And then also the obstetrical perineum, which is called the fourchette. And then you have these. So that's the, the landmarks. And then here, the urethra and the Skene's ducts. You gotta remember all this. And vaginal introitus, the hymen, and the ducts of Bartholin glands. The Bartholin glands actually lubricate and come very important during like sexual arousal, but they're not visible. They're kind of hidden. And then your perineum, which is the site of the episiotomy. So there's 2 types of episiotomy, and these are surgical cut. They're midline, and then you have it in perineum, and then you have the medial lateral. The surgical cut is, if the head is too big, there's a big baby, you've got to, and the skin has stretched totally. You have to cut episiotomy. Now, what and midwives, what we try to do is really stretch out the perineum with some massaging. But this is a site again of the episiotomy. And then here, this is another side view of internal fetal female reproductive organs. So reason why I like to show this is because you see the fallopian tubes, okay? And because remember, when we talked about complications during pregnancy, I think it's in one of the chapters, you talk about ectopics. So here's your fallopian tube, okay? And what happens in the fallopian tube? You know, what happens in here?
That's where the egg is
Yep, you got it. Keep going.
and the top of the fallopian tube, like I think the third.
Yeah, right in the ampulla of the fallopian tube, right in this area where I got this little arrow. This is where fertilization occurs.
Yeah, fertilization.
Okay. Yeah. The sperms make their way up. And they got to travel a long way. They got to be good swimmers, by the way. And they come up and they meet the ovum and then their fertilization. So is that I think that's a really good question, don't you think?
Yeah.
Yeah. Okay. So fertilization. And then after it fertilizes, it travels through the fallopian tube. It goes through mitosis, and which is cell division. And then what happens, it makes its way through the tubes into the uterus, okay? And that's where implantation occurs. So write down implantation, because implantation occurs in the uterus. Okay. So here we have is the cervix, and that's important when we talk about labor and delivery. And then right underneath the uterus, so here's the uterus. Right underneath the uterus is the bladder. Now, when the bladder gets inflamed, or they get a little bacteria in there, it gets infection, and can maybe have a UTI. Then that puts pressure on the uterus. That actually aggravates the uterus, because the uterus, remember, is made up of 3 different muscle fibers. They're all interwoven like this. So what happens is that, as the baby grows, the uterus grows to accommodate the baby. The uterus doesn't blow up. It's able to expand. And that's the only organ in the body that has 3 different muscle fibers. It's really neat. And then you have the bladder. So that's why we worry about UTIs, because a UTI, urinary tract infection, leads to preterm labor. And then here's another landmark, is your rectum. And you want to make sure that this, that she's not constipated, because constipation can also throw a woman into preterm labor. All right. So let's talk about the uterus. All right. So remember, that's where you have the fertilized ovum implants, like we said, and develops into an embryo. Okay. So remember, in the fallopian tube, you have fertilization. And under mitosis, it goes ahead and cell divides, becomes a zygote.
Can I say something? And whenever we see the word ovum, that's basically the egg, right?
Yes. Yes.
So it's just ovum, egg, ovum, egg.
Ovum, egg. Yeah, that's right. Gotcha. You got it. Okay. You got it. So then what happens, it turns then when the sperm and the ovum comes together, the egg, okay, and they work hard for that. Then it becomes a zygote, and then that travels through the fallopian tube and makes its way into the uterus. Okay. And where it implants is in the upper portion of the uterus, on the posterior wall. And that's where it implants. And you know what? It's a really good place for it to implant. It kind of burrows down into the endometrium, is because it's nice and kind of out of the way, and it can grow. And there's a lot of rich blood there. Because don't forget, when she didn't have her period, when a woman doesn't have her period, that uterine lining, it becomes very rich in blood and is ready for the zygote to come in, or the blastocyst to come in and to burrow into it. Okay. Now, when you're looking at like an upside down pear, you can think of the uterus. You know, I always tell my students, go to Publix or go to your grocery store and look at a pear and put it upside down. And that's exactly what a uterus looks like. Because mostly, don't forget, the uterus is small and usually is laying down in a woman's pelvis. And around week 10, week 11, it starts to grow, come out of the pelvis and into the abdominal area. And then the uterus becomes a temporary abdominal organ. Okay. All righty. So we talked about where it lies, and we talked about the bladder and the rectum. And don't forget, there's a lot of sensation that goes on. There's a lot of motor and nerve roots that supply sensation to the uterus. All righty. And the reason why I'm pointing that out is because, you know, it's so sensitive that, you know, the woman has, you know, unfortunately, they experience pain during the labor. Okay. All righty. So here I show you exactly a nice picture of what it looks like. And I love this picture because it really shows you the landmark. So here's your frembre, which is your little finger-like. And this is going to grab in here, in the ovary, it has a lot of follicles, okay? And when one matures, is released, and then this frembre comes up and grabs it, and then it travels through the fallopian. And when a sperm has made its way up, and write this down, it only takes one sperm, that's all she allows in, and only one sperm.
The fallopian tube only takes one sperm?
No, the ovum only takes one sperm.
The ova only takes one sperm. Gotcha.
Yeah, she only allows one in. She says, all you other guys, sorry, you can't come in. Okay. So one sperm gets in. And then what happens, Alan? She puts like this aura around her egg. And that is like a barrier, say. And so no more sperms can get in. They go, oh, I guess that's it. Okay, all those others will die off, and they do. They just die off. And then you have the meiotic cell division, and then it travels into, let me get my little arrow here, into
I have a question.
Yes, go ahead.
So how they have the twin? How they get?
Well, the
There was only one
twins, you
sperm.
have dizotic and you have monozotic. And what happens when that sperm, it's still just one, but what happens is when it divides, it's gonna divide into two. So, and then so dizotic would be, there's one bag, they're in one little sac, and then the dizotic would be the two. So the monozotic is identical twins, and the dizotic is fraternal twins. Make sense?
That's amazing. It's amazing.
Amazing. Yeah, it's amazing. And so you come in here. So what I want to point out to you is, see the top portion of the uterus? That's called the fundus. Very important, the fundus, because the fundus is what we feel when we're checking to see if it's soft or boggy, or because that's the powerhouse. Right? Just write that down so you have it for future too. The fundus is the powerhouse of the uterus. This is where contractions actually begin. And then they make their way down through all, because don't forget, there's a lot of nerve and sensation, you know, nerve endings there. Okay. And then here, just to show you, because you'll probably, when we talk about labor and delivery, you'll say, oh yeah, I remember that. Okay. And here's the broad ligaments. So the same ligament that holds up a non-pregnant uterus will hold up a pregnant uterus. Okay, so that's why sometimes women have pain in ligaments. They have a ligament pain. They'll say, oh man, my legs kill me. My leg, say like my right leg, all the way down from my my groin all the way down to my feet. That's what they're talking about. They're talking about broad ligament pain. Okay. All righty. So, and then I just went over here, just some of the different layers of the uterus. And again, the fundus is your powerhouse. Okay. And you can see over here, this is really nice drawing, by the way. I believe it was in your book. This is the follicles you can see. And so see this one here, when it matures, then it releases. And then she makes, and then then fertilization occurs in the fallopian tube, and then it comes into the uterus. Okay, I think we conquered that one pretty good. All righty. We talked about the cervix. The cervix is right here. Cervix has an internal os and an external os. So when you have an internal os, it's really the closest internal opening near the uterus. And then the external os is actually entry into what? The vagina. Okay. And then you have the mucosa lining. And what you got to think about is what does this lining do? All right. So one, it will lubricate the vagina, which she needs. The Bartholin glands are very much so. They act as a bacteria agent, bacteriostatic agent. We want to keep, guys, bacteria from going up into the uterus, because bacteria, what happens when bacteria enters, it can go up into the uterus, and because bacteria ascends in a woman. Okay, so that's why, that mucus plug that you probably already talked about in another lecture, mucus plug actually prevents that bacteria from getting up into the uterus. Because if that's not there, then what happens is that, remember the chorion and the amnion, those layers of the uterus, they can get infected. And remember something, if mommy gets infected, the baby gets infected. Okay, they are one together. Okay, all right. Okay, so here I wanted just to show you about the fallopian tubes. Again, it's the site of fertilization, passageway for the sperm to meet the ovum or the egg. And it's really a nice self-nourishing environment for the ovum and the zygote, which is your fertilized ovum. And then again, the fallopian tube is the one that transports the celiac motion to the back into the uterus. All righty. And I gave you a little thing on the ovaries. The main function of the ovaries is mainly producing two hormones. Now write these down because we're going to go into these a little bit more. Estrogen and progesterone. Okay. All right. So if I was to ask you guys a question, where does the zygote implant? What would you say?
Can you say that again? I was writing.
Okay, sure, Alan.
And can you get it's estrogen and I'm sorry, I'm trying to write that down. Can you go back?
Oh, sure. So
estrogen
Alan,
and progesterone.
Yeah, write down estrogen, then write down progesterone.
Got it.
Okay, because we're going to discuss what each one of those does in just a minute. They're both very needed in maintaining the pregnancy. Okay.
And they're hormones.
Yes, they're hormones.
Okay.
They are hormones because they come from the ovary. See, an ovary looks like a walnut. See here, this walnut? That's what an ovary is. It has the size of a walnut. So maybe it gives you a little visual. You can think, okay. And that produces the hormones estrogen and progesterone. And you need these hormones. You need progesterone to maintain the pregnancy. Okay. Progesterone maintains the pregnancy. All right. And estrogen is a stimulant. It helps to produce those endometrial lining of the uterus. But I'll go on. I'll go in more into depth in a minute on all of those. Now,
what was that question? I'm sorry.
All right. So let me ask you the question. All right. So does the zygote, say yes, or you can say true or false. the zygote will implant in the upper portion of the uterus.
True.
True.
True. Very good. Okay, you got it. Now, another question. Which part of the reproductive system is the nurse referring to when she talks about the passage between the ovaries and the uterus?
The fallopian tube.
tube.
You got it. You got it. Okay. All right. So those are things I want you to remember. And then and then don't forget about implantation. Okay, good. You got it. All right. Well, we did that. We did implantation. Good. All right. All right. So here's your different types of pelvises. Remember these from your book? So your gynecoid is your most favorable for a vaginal delivery. Okay. So look at these. So like when you're looking at them, you can see that this here, a baby's head could get through that pelvis nicely. All right. But you see this android is what? Is skinnier, right? It doesn't have that nice, like rounded shape. All right. It's more tapered in, right? See this? This is really a male. This is very common to a man's pelvis. Okay. And then you can see this anthropoid. Can you see the difference between this one and this one? And again, it's not as rounded, right? And you can see
Right.
almost a baby's head coming through here if you really look at it. And this one, it's a little harder. Okay, they can deliver with this pelvis, but it's not easy. Okay, so see how nice and round that is again? Now look at this planetoid. Okay, this is like a pancake, like a plate, right? It's not good. Okay, this is not a good pelvis for a vaginal delivery. No, 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 no. So that's what I want you to remember. So if I was to ask you, which pelvis is the best for a vaginal delivery, and your response would be
Gynecoid.
Gynecoid.
gynecoid, right? Okay, great, good. All right, we just answered that question. All right. Okay, and then in chapter 2, we talked about the breasts, and remember it produces the milk after birth. And remember where the milk is produced is in the glands, right? So breast size does not matter. Okay. Yeah, right. Okay. Because it has nothing to do with the breast size. So it has to do with how they're produced. They're produced in the what? The glands, right? So just kind of keep that in mind in case you see that again. All right. Okay. Now, here you're going into the menstruation cycle. I know, I think, Alan, you probably have a little harder time with this. Okay, because, it's hard, but what happens is that
Don't feel bad, Alan. Me too.
I'm just glad mine are done.
I do have a wife and a daughter that's going in her teenage years, so.
Oh, you do?
Mhm.
Okay. So then you understand, okay. So now when you're looking at the cycle, so a cycle means what? It means it goes through stages, and then if something doesn't happen like pregnancy, then she sheds off that endometrium, and then it starts all over again. Okay, the follicle stimulating hormone, which is the FSH, and the luteinizing hormone, okay, which is the LH, they stimulate the maturation of the ovarian follicle. Remember I pointed out those follicles to you. That's what's happening. So those follicles, then they mature, and then what happens? They release it, right? Boom. The ovary releases it, and the little flembe, the little finger-like, they pick it up, and then it goes through the fallopian tube, right? And then if pregnancy occurs, then we have now estrogen and progesterone that's going to come into play. Okay. And so this is what happens. So you have the surge of the luteinizing hormone that stimulates the final maturation of that follicle. And then I told you it releases it. Okay. So here, I just put in here the little menstrual cycle and what happens. And in a cycle, and let's talk about a 28-day cycle. Because, cycles can be 32. Some women have very irregular cycles. And so we're going to talk about a 28-day cycle. So I know Hesse likes this kind of question. If you have a 28-day cycle, then if ovulation occurs on day 14, okay, of a 28-day cycle. So here you have your luteinizing hormone, you have your follicle stimulating hormone, your follicle is released, and then you have the different, here's your egg getting ready, and here ovulation. Now, ovulation is the primary time, guys, to get pregnant. Okay, you ever see those kind of cartoons or shows, and they say, "Oh, honey, my ovulator and my calculator says it's time
Yeah.
to have sex because I'm ovulating." Okay, that's the ultimate time that now the woman can get pregnant. And so that's why ovulation is important, because here you can see what happens here. You have the prolific time, which things are happening, the hormones are going, and then you have your FSH and your LH, and they're getting those follicle ready. And then she sends out the little ovum, and here we're ovulating. And see how nice the endometrium of the uterus is? It's ready. Okay, it's ready. And sometimes they talk about this time being the inside the uterus very like really rich in blood, and so like a velveteen, red velvet, and it's very rich in blood, ready for, if fertilization occurs, it's ready for that little blastocyst, the zygote that changes into the blastocyst to implant right here. Okay, and then you can see how now this is really getting very thick. Okay, this is the secretory day of the cycle. And then guess what? Here we're really, look at how nice this is. We're ready for that implant. All right, so this is how it works. Now, if she didn't get pregnant, okay, then there was no, ovum and the sperm did not connect due to birth control, then she has her period. And see here, now she's shedding. So all this beautiful soil is now going to be shed off as blood. And this is the period time. So that's what's really happening during this time. And this is why it's very important that when you're counseling young girls that they know about it. Okay. Now, on a little girl, a lot of questions are on tests about, when the first menses occur, or what happens in the development of the young lady. So what we see first is little breast buds. They come out, and then her first menstrual period is called the menarche. That occurs approximately 2.5 years later, around 11 to 15 years of age. Now, it does vary in teenagers. If you have a very athletic young lady, sometimes she gets it later because they experience longer periods of amenorrhea than, say, a young lady that's not so athletic. What comes to my mind is the gymnasts. They have such little body fat on them that they are usually have a delay in their amenorrhea. Okay. But during that time, and this all happens, she gets her breast buds. That's the first sign that something's happening. Then what happens? Her hips get a little broader, and then axillary hair starts, and pubic hair starts. So let's go back to ovulation, because I just love ovulation, don't you? So ovulation. So you have the mature ovum I talked about. It's released from the follicle, remember, in the ovaries, and it's 14 days. Okay, you see that in red? That's pretty important. 14 days before she starts all over again on her menstrual period. Okay, And what happens is this corpus luteum, it turns yellow and then it secretes quantities of progesterone. You have to have progesterone to maintain the pregnancy. Okay. And so let me give you an example. You know, when I have patients that come in and they're trying to hold a pregnancy, maybe they're infertility and they just had their IVF, they're going to get injections of progesterone before to get them ready because they need that progesterone. When women are aborting a lot, when they miscarry a lot of times what we'll do is we'll order some lab works and we're looking for their hormonal levels and we're looking for the progesterone level. Okay. So now getting back to the corpus luteum, if the ova is not fertilized, okay, didn't fertilize, then your progesterone and estrogen levels will all go down because there's no need for them. You got it? There's no need. There's no pregnancy. Okay. And then your endometrium, which is your inside the uterus, what all that beautiful blood was, is there's no need for it. So it sheds it, it gets rid of it. Okay. And then woman has her period. And then guess what? It all begins all over again. All right. And so here it just shows you over here, shows you like her fertile time, which is here, ovulation day 14. Okay. And then she goes through the cycle. All righty. So this is my nursing tip. So during sexual counseling, the nurse should emphasize that the survival time of sperms ejaculated into the area of the cervix can be up to 5 days. Okay. And that pregnancy can occur with intercourse as long as 5 days before ovulation. So this poor woman doesn't have very much time because 5 days before she ovulates, that's like 1, 2, 3, 4, 5. From here all the way to, let's see, 1, 2, 3, 4, 5 to here. Okay, that's not a good time. All right, because sperms, they can live a long time. They can live up in that cervix 5 days. So this is why we use a calendar and we go over this with young ladies when we're counseling, because we have to tell them, you have to be very careful, 5 days here, 5 days here. So how much more time does she have left? Not very much. Okay. All right, so that was the highlights of chapter 2. All right. That was in a nutshell, but that's the most important parts of chapter 2. So now we're going to go into chapter 3, fetal development. Okay, how this little guy comes all together? Well, you know, they're all made up of DNA. You know, our DNA is who we are, correct? Yeah.
Yes.
You know, if we have dark hair or we have green eyes, that's all set in stone. All right, we are who we are because these little cells, okay, they have these chromosomes. And so you have 22 pairs of autosomes and 1 pair of sex chromosome. All right. And these chromosomes can be influenced by teratogens. Teratogens are things that can do harm to the fetus, to the embryo. So like external environments, okay, where the person maybe is working, the girl's working. If the girl is using drugs, definitely can be a teratogen to that embryo. Remember, the embryonic stage is from week 2 all the way through week 8. That's when the embryo itself is developing. Then at week 9, it turns into the fetus, and then you have fetal development. Then you have everything gets set. All the DNA, everything gets set in the embryonic time. Now, does a woman really know she's pregnant at 3 weeks pregnant? No. She may be having, you know, time out with her girlfriend, maybe having a few drinks. That could harm, that's a teratogen that could harm an embryo. So things like that, you know, when we talk about all this, we really would love people to come in pre-conception, like very planned, is because we can start them on vitamins and folic acid way before they even become pregnant. That's the best time. But anyway, getting back to here, and so you have, and then if she's under not eating well, she's not being getting the proper nutrition, that can also affect a growing embryo. So don't you find it's amazing that we all ended up really good, considering what could have happened to any one of us? Okay. And then of course, smoking. Smoking is a teratogen to this little embryo. So all this biological development are influenced by everything that the woman is surrounded or taken in. Because what mommy takes in, baby gets. All right. I always said healthy mommies, okay, equals a healthy baby. Okay. Nothing's guaranteed, but if we start out correct, you do get a healthy baby. All right. So I went over fertilization quite a bit already, as we discussed it before. But again, I just wanted to make sure that you all realize what occurs in fertilization. The sperm penetrates the ovum, and then they unite, and it occurs in the outer third of the fallopian tube. I think you got that now. Okay. And here, I just love this picture. This shows you, here's your follicles. Remember the FSH, follicle stimulating hormone, the luteinizing hormone makes the maturation of these cells. Then the follicle gets mature and is released by the ovary, right? And then these little hands, they're called the fimbriae, the little fingers, it grabs onto it. And then here we got the oocyte in the tube. Here it shows the fertilization. This is the ampulla of the fallopian tube. Okay, cell dividing by mitosis changes into now a zygote. And then you can see cleavage starting here. That's cell division. So you go from a 2-cell to 4-cell to 8-cell, and it keeps dividing. Then it becomes a multiple cells, and that's called a morella. And then it becomes a blastocyst. And now we're going to find our way into the uterus, and that's implantation. So I think you got that pretty good. And so I won't go over it again. I think you got this. Are you guys good on this?
Mhm. So the zygote's definition basically is a fertilized egg, right?
You got it. You got it. Okay, I think we got it. Good. Okay, and then here's implantation. Again, it's the term. Now you might see that one again. So I would know fertilization, implantation. Those are really important ones. And then the fallopian tube. Okay.
I always get mixed up with the fertilization and implantation.
Yeah, I would know
Kinda
the
hard.
difference because I think this was on your quizzes, and a lot of people get those mixed up. That's why I guess I put it in here quite a few times to show you the difference. Fertilization occurs in the fallopian tube. Implantation is in the blastocyst is implanted in the uterus. Yeah.
Yeah, you just got to remember fertilization, fallopian. Fertilization, fallopian too.
Okay, so you see, I love pictures. So I saw another picture, came across, I said, oh, got to put that in there. Again, it's the same thing. And here's your fertilization. So, these little sperms have to have great motility to make it up, because they have to go against the grain here. They're going up, and then they have to travel. And there's little hairs that are inside the fallopian tube called cilia. And that cilia motion travels those sperms toward the ovum. And then here they found, this one, lucky guy, he found her. And they came together, and that's the beginning of life. That's your fertilization. And then they make their way into the uterus. Okay, good. Okay, so let's talk about some hormones. So HCG, the human chorionic gonadotropin, this is the one that's very detectable in blood and urine. This is the one that you can buy like in the dollar store, or if you go to a doctor for the first time to find out you're pregnant. This is that test. That's the hormone that's picked up in the very beginning of pregnancy, is HCG. So there is in red for you. HCG is the hormone detected in early pregnancy for a positive test. Now, if my test, guys, comes out equivocal, and equivocal means I'm not sure. Is it maybe? Okay. Well, you can't say to someone, well, maybe you're pregnant. Say, we're not picking up on the urine test. So I'm going to send you for a blood test, and we can find it in blood serum. Okay. And I can get a really good level. I can get a quantitative and a qualitative levels of HCG in the woman's body. So this is the HCG is the one that can be detected early in pregnancy. All right. Now, the sex of the baby is determined by the father's sperm. Okay. And like I've had patients in the delivery room where the father wants, say, a boy. Okay. And he has a whole bunch of girls at home. Say he had 5 girls at home. Okay. So they couldn't see on ultrasound what they're going to have. So in the delivery room now, the baby comes out and it's a girl. So he has another girl. Okay. I've had fathers get really upset in the delivery room over this. And I look at them and I say, I tell you what, you know what? It's you, the father, who determines the gender of the baby. And now they're really quiet. So again, it is in some cultures, the conception and birth of a child of a certain sex is a source of concern to some families. Okay. And I can tell you, I have experienced that myself in these delivery rooms. All right. So I want to talk about now how this all comes about. I told you about the embryo already. It's from week 2 to week 8. And this is what it develops from the trophoblast, and it has the amnion. There's different layers, but you're going to have the amnion, you have the chorion, and then you have the yolk sac. And the yolk sac does die off and become a ligament when the placenta starts to take over. Okay. All right. Let's see. And then you have the amnion, which is your second membrane. Okay. So what I want you to get out of this is together with the chorion and the amnion, they form an amniotic sac. Okay. That's where the bag of water, comes from. Okay. They filled with fluid. That's the bag of water. Now write this down because this is important. Amniotic fluid is clear. It has a mild odor. Can contain some bits of Vernix, remember Vernix caseosa, or Languga, which is the fine hairs. Vernix caseosa, in case you don't know, is the body cream. That really thick, I call it nature's cold cream. Baby is covered in that to protect the baby's skin while it's laying in this bag of water for like 9 months. Okay. All right. So those are important to know. Again, especially when you get into laboring, the labor and delivery area chapters, we're going to go over more with amniotic fluid, and you want to note that it's clear. It shouldn't have anything. It should not be green or brown. No, it should be clear and has a mild odor, because remember, anything that has a foul odor, okay, is never good. That means it's infected. All right. All right. So I would definitely know this one. This is your function of amniotic fluid. I think you saw that probably on one of your quizzes. Yeah. So it maintains the even temperature in mom's belly, okay? Amniotic fluid. It's important, okay? Prevents the amniotic sac from adhering to the fetal skin. Think if the baby wasn't in any water, okay? It could eventually stick to mom's inside of her uterus, okay? So this way, the baby can float. You know, he floats up and down, or they do all kinds of stuff in there. And so, you know, you have this baby is floating in the amniotic sac. His skin is not adhering to anything, and so we're okay. Also, very important, it allows the baby to grow symmetrically. All right, so that means that like my right hand and my right arm and my left arm are going to be the same length.
Mm.
If I didn't have that amniotic fluid, I could be that maybe my right arm would be longer than my left arm. Okay, so this way baby can bounce around and can grow nicely, symmetrical growth of the fetus. And then again, it allows the baby to bounce around, full buoyancy, and for fetal movement. You know, fetal movement allows mom to know, hey, I'm in here and I'm doing okay. Because movement takes what? Takes the brain. It takes it neurologically intact. The baby's good. So fetal movement is always good. That means my cardiac, my little heart is doing what's supposed to be doing. It's keeping me alive. I'm doing good in here, mom. And then the last thing it does, it acts as a cushion to protect the fetus and the umbilical cord from injury. Because you have this little fetus and you have the umbilical cord. And now the umbilical cord is actually protected in this water by, it's called Wharton's jelly. That's WHARTON''S. It's called Wharton's jelly. And that
Repeat that.
Oh yes, Wharton, WHARTON''S. That jelly surrounds this cord, and that keeps the cord from what? From getting saturated with fluid. So it protects it like a jelly. And so you have that because, and then you have the baby floating. Here's your amniotic sac, and the baby's floating, so the baby can move. Like I said, the limbs will grow symmetrically. Okay, it acts as a cushion too, which, you know, when mommy, you know, maybe hits her belly against something, and you know, the baby is okay because it has a cushion. There's, you know, it protects, it surrounds the baby, so baby's in like a little capsule. Okay, so those are the functions of amniotic fluid. Okay, you guys got them?
Yeah.
Okay, good. Okay, and then, you know, we talked about this already, but we can just look at it again. These are the stages of prenatal development. The prenatal time is so important to get a healthy baby. Mommy, vitamins and folic acid. So zygote is, we talked about this, that's the union of the sperm and the ovum. Excuse me. The embryo is the 2nd to 8th week of development. We talked about that. And the fetus, so the embryo has its own embryonic milestones, and the fetus now will turn into a fetus. This little embryo now goes into a fetus at the 9th week, all the way to birth. And then you have the age of viability, and we say it's 20 weeks gestation. Now, 20 weeks is a pretty early, okay? But this is our, in labor and delivery, we have that cutoff. Okay, so anything below 20 weeks, we can't really do anything. You know, when a woman's got and having you know, a miscarriage, and she's at 16 weeks, we can't do anything, okay, to save that baby. That baby is not viable to live. When I say viable, I'm talking, the definition is the ability of this neonate, this fetus, to live outside the mom's womb, okay, outside of her womb. So anything below 20 weeks, such 16, 14, 18, that baby, when it's born, will not survive. Okay, it's not viable. It's not able to survive outside of mom's tummy. Now 20 weeker is still very early, guys, real early, but Some babies are born like maybe a pound at 20 weeks, okay, not even. And so we take that little bitty little thing and it goes to the NICU, the neonatal ICU. When a baby's that early, we have that NICU team in the operating room or in the delivery room. Usually those kind of babies you deliver by cesarean because you don't want to create any kind of intracranial hemorrhages. And it's very easy, those real young babies to have problems. Okay, so that's viability. So here, this is at 9 weeks. This is when the fetal stage now, okay? And then they grow. So 12 weeks, you have your sex organs, okay? By 16 weeks, you got your finger and toes, okay? By 20 weeks now, this is 20 weeks where we do that ultrasound at 20 weeks to, see the anatomy of the baby. And it's a good time if you want to see if you have a boy or girl, this is a good time to do so. Even though this is one of the sex organs, they only differentiate in 12 weeks, but you really can't see anything that's that early. So we got to 20 weeks, we do the ultrasound, and we can then see the chambers of the heart. We can see the feet, the toes, the hands, the fingers, and we see the baby very well. So we do an ultrasound then. And then you have 24 weeker, the lungs begin to develop. They start about 24 weeks to produce surfactant. Write that down, surfactant, surfactant, surfactant. That's an important term. All right. And then you have 28 weeks, and surfactant, I think they tell you, surfactant is it's a protein that allows the lungs to breathe in and breathe out, breathe in to move. So like in a car, I always think of oil in a car. You need oil, right, in a car to have the engine to go, okay?
So surfactant is lung development?
Yeah. So the lung surfactant itself allows the lungs to take in a breath and to release it up and down, in and out, inspiration, expiration, okay? So surfactant is only being produced at this time. So if you have a baby born at 20 weeks, he doesn't have that ability to breathe on his own when he comes out, okay? Because he doesn't have the surfactant. This is when surfactant begins to really take hold. And then the lungs begin to really develop. Because babies don't breathe inside the uterus.
So from 24 weeks on to whatever, 40 weeks or 39 weeks or whatever, the woman's body is producing the surfactant.
The woman's body, actually what happens, surfactant is in the baby. And so the baby it produces this protein, and the lungs are able to now develop. And this is only when they begin to develop. Okay. So babies born at 20 weeks, they need a lot of help. They go immediately to the NICU because they don't have that ability to breathe like these babies would. Because right now on 24 weeks, that surfactant is being released in the baby's system for those lungs to take a breath in and to breathe out, in and out, and they need that protein for the lungs to go in and out. And then as they get older, like 28 weeks, now they're going to have more surfactant. Okay. They're gonna really be able to survive outside because now they have more surfactant. And this is where 28 weeks, the brain. And I'm going to tell you, the latest studies on this, the brain actually keeps developing up until term, 40 weeks. Okay. All right. And then you have the bones are fully developed now at 32 weeks. And 36 weeks, they're now fully developed. And then a term, you have full term development. So you have the brain developed, they have the ears, they have the lungs, They have their bones. So they're ready at 40 weeks to come out to be born. Okay. So you can see the difference between a 20 weeker and a 40 weeker, right? So a 20 weeker, they're just barely. Okay. And their skin here at 20 weeks is very transparent. They don't have any brown fat on them. At 40 weeks, they have brown fat. So there's a big difference. So here's the placenta. This is what nourishes and keeps that baby going. It takes waste products away from the baby. It's a connector between mommy and baby. Okay, and this is what I call the lifeline. This is the cord. So how many arteries are in this cord?
It's I know it's two of one and one of the other, veins and arteries. I know it's
Two arteries, one vein.
Yes.
Two
Two
arteries,
arteries, one vein. So write this down. AVA. 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 Artery, vein, artery.
Okay.
Think of Ava. Ava, darling. Okay. So Ava. Two arteries and one vein. That will help you. Now this side, what side is this?
That's what side? I know it's not the maternal side. I know.
Okay, this is the baby, the newborn.
The baby side, yes.
Right.
The baby.
This is called the Schultz. SCHULTZ. And how I learned it.
Repeat that again. Sorry, you're going
Sure.
too fast.
SCHULTZ. Now I'm going to
And
tell
that's the
you.
newborn side.
Yes, now Nicole, you can remember it this way too. Doesn't this look shiny to you?
Yes.
Okay. It's a shiny Schultz.
Okay.
SS, shiny Schultz.
Mm-hmm.
Now the maternal side is not so pretty because don't forget, the maternal side was connected to mom's endometrium. So that has like more lobes to it. Okay, it's not as pretty as the Schultz side. The mommy side is called the Duncan.
Duncan?
Yeah. Okay. So now how you can remember this? The mommy side is not so pretty. It looks dirty. So you call it the dirty Duncan.
Oh, okay.
So you have DD. If you learn it, if you memorize it that way, you'll never forget it, guys. Believe me.
Okay.
All right. So neonate side is shiny Schultz because it's beautiful. Look at that beautiful this placenta is. I mean, it is rich. It is rich in blood, beautiful blood. Look at that cord. That cord is good. The cord is usually around 22 centimeters long. It's a nice cord. It
looks like liver.
That's beautiful cord. There's no like yellow film over it. Now, let me tell you, if you had if mommy smoked, this cord would not look this way. It would be skinny. It would not have this beautiful, because don't forget, this was all filled with blood before. Now that it's draining out. But it doesn't look like this. It's real skinny. And it has, I know I was going to tell you, it has like a film over the cord. A yellowish tinge to if you ever see a smoker's hand, you'll never forget it because it's all yellow. And it's not pretty at all. Okay. And a smoker placenta would not be as big as this. This is a nice big placenta. So this was a good pregnancy. This was a good sized baby and it was a good pregnancy. Okay. So and two, you can see where the cord is inserted into the placenta. Then this would be connected to the baby. So that's why also that's a giveaway that where the cord is inserted is the neonate side. Okay, you guys got that?
Yep.
So what is the mommy side called?
Schultz. No, the mommy side is Duncan. Sorry.
Okay. And what's the baby side called?
Schultz.
Okay. All right, so what is, now we looked at the placenta. So what is it used for? It's used for everything the baby needs. To breathe, for fetal respiration, for providing nutrition to this baby, and for excretion. Okay, so this beautiful placenta has its own hormones. Okay, the hormones are progesterone, estrogen, HCG, and it has its own human placental glycogen, which comes into play with sugar, because baby also needs sugar for energy to grow, right? So these are the different hormones of the placenta. All right. So now you know, you can be able to recognize the question, the difference between the placenta, what the placenta is used for, and what the, right? You got it? All right. Are you there?
Yeah.
Okay. All right. So write this down. Remember I told you to write down estrogen? So estrogen stimulates uterine growth.
Let's see who growth.
Okay. Write that down. Estrogen
Okay.
stimulates uterine growth. Okay. It increases the blood flow to the uterine vessels. Do you need estrogen? You certainly do. And it stimulates the development of the breasts. You know, remember the breast, the ducts? Excuse me, to prepare for lactation. So just remember, estrogen stimulates uterine growth. The blood you need, you know, in the uterus, the vessels in the uterus needs what? The blood. It needs the estrogen to increase the blood flow to the uterine vessels, because you need blood. Now, the effects of estrogen, not related per se to pregnancy, but it does happen. Estrogen increases your skin pigmentation. So they know that.
Is that the liner, the lane, was it the lane?
What's that called, Nicole? What's that called?
I don't know how to pronounce it. The linear gray, something.
Linea
Linea.
negra. That's the line that goes up the middle of her belly. Okay. And that also starts out as white, alba. And with estrogen, as the pregnancy goes on, it gets dark. Okay. It's also the effect on the mucous membranes. So like the mouth, she has increased saliva. Now I'm going to tell you.
Some people spit?
Yeah, they spit. I had a patient that was spitting all the way through her labor because she had so much saliva. Okay, you ever hear of women having nosebleeds?
I heard of it in class. I've never witnessed anyone.
It's because of estrogen. Estrogen is the culprit. It does all that. But do you need it? So my question to you, do you need estrogen?
Yes.
Yes, you do.
Yes.
Yes, because it's responsible for stimulating the uterine growth. Now, our progesterone. Progesterone is so important because it maintains the uterine lining for the implantation of the zygote. Remember that beautiful lining I showed you that is really rich and that we call like a red velvet? That's progesterone. It has to have that for that zygote or the blastocyst to go ahead and implant and burrow down properly. Now, estrogen is also the one that reduces uterine contractions. You need estrogen to maintain the pregnancy because it maintains the pregnancy by reducing uterine contractions. When women are habitual aborters, when they have spontaneous abortions, and then you definitely need to know what's their progesterone level. That's why we give progesterone injections. And then progesterone also. Now they prepare the glands of the breast. Estrogen, it is responsible for the ducts, and progesterone is responsible for the glands. And then progesterone stimulates the testes to produce testosterone, which aids male fetus in developing the reproductive tract. Do you need progesterone?
Yes.
Yes.
Yes. Okay.
Both men and women, right? Seems like
Right.
it's both men and
Yeah, you definitely need both all these hormones to maintain a pregnancy. Without estrogen, you would not have uterine growth or blood flow to the uterine vessels. Without estrogen, you would not have the development of the breast ducts. Okay. Without progesterone, your body would sense that something's not right and would try to get rid of it. So it would get rid of the little zygote, the little embryo. So you need progesterone. Progesterone reduces uterine contractions. Progesterone maintains this uterine lining. Very, very important. This is why women lose their babies. They're in the very beginning is because they don't have enough progesterone. Okay, now human placenta lacogen. Oh, did I go over HCG? Yeah. Okay. All right. So lacogen is what? Sugar. So what happens is that it helps to make more glucose available to the fetus to meet his growth needs.
Is this one of the 4 hormones the placenta produces?
Yes.
HPL. Okay.
Yep. So HPL, HCG, estrogen, and progesterone. You got it. So that's why you need all these. All right. Now,
you said the 4th one was HCG.
Yes. Remember the human gonadotrophic hormone.
That's the one that the positive pregnancy test, right?
Yes. It can show up very early. Yes, that's the hormone that shows up very early in the pregnancy test. Yeah. You got it. You're putting it together. The dots are connecting. That's good. Yeah. Okay, good. Now we have the 2 arteries, right? So through these 2 arteries, you have fetal deoxygenated blood and waste products that leave the fetus. So write down 2 arteries equals fetal deoxygenated blood. That means it's not oxygenated. And so this blood and waste products, they leave the fetus.
So you said write down the 2 arteries equal deoxygenated blood.
Yeah. And reason is, remember, this is deoxygenated blood. So you got deoxygenated blood and waste products that leave the fetus. It goes back through the placenta and it goes back to mom and gets discarded.
Yeah.
Yeah.
And the vein, the vein is what takes the oxygen in.
Yeah.
And the arteries take out the
right. You got it. You got it. Yeah. Yeah. Gotcha. It's a little backwards from our regular circulation. That's because a baby doesn't breathe in utero. So it doesn't get oxygenated through the lungs. Okay. It gets oxygenated through what? Through the placenta. See? So that's why you have this situation, this setup. It's so good. All right. And so then as the baby grows and gets closer to 40 weeks, then he starts to breathe a little bit inside in order that it starts now, because he has the surfactant, he starts to breathe so that when he's born and the cord is cut, he's on his own. He's able to breathe. That's the biggest job for the neonate when they're born, is for them to breathe. Absolutely. Okay. So I just gave you a little explanation here that fetal and maternal blood do not normally mix. Okay. They should not mix. So now you have this oxygenated, nutrient-rich blood from mom. Remember, mommy's supplying the baby. It goes into the little intervillous space in the placenta from the spiral arteries and the decidua, which is the endometrium. And that's how blood circulates from mom to baby. All right. Now, fetal blood releases carbon dioxide and waste products, and it goes out the body through what? The arteries. You got it. Are you guys good on that?
Yeah.
Good, good.
Yes, ma'am. I'm
So
listening.
here, isn't this a pretty neat picture? So here's your little fetus, and he's got the eyes already started. You see, he's got his feet and his little toes. Here's your umbilical cord. That's what it says, the baby's lifeline. And you can see, you know, the internal organs. And so, and here's the head, the brain. Okay, it's got a lot of growing to do. This is very early, but you can see how we developed. Okay, so again, I put another slide up about the placenta transfer because I know a lot of students get this kind of mixed up, but you guys are doing great with this. So I will let it go, but just remember, fetal blood takes oxygen and nutrients before returning it to the fetus through the umbilical vein. So we said that, vein, oxygen, right? And nutrients. Yep. Okay, good. Now this is where it comes in. So you see, anything mom takes in will cross the placenta and get to baby. So mom takes drugs. The drug molecules will cross the placenta and get to baby. The only molecule that's large, that's very large, that does not get to baby is insulin, by the way. But everything else will cross the placenta barrier and get to baby. That's why you be so careful of nicotine drugs, you know, viruses, because these can cause problems and cause infections. And mom taking drugs will cause the baby to be addicted when he's born, okay? Because he's getting fed these drugs, you know? And so they have a terrible time. Mom is an alcoholic. The alcohol molecules will get into baby's system. Babies are born with fetal alcohol syndrome. Not a pretty sight. Okay, so again, here we are. I just say, you know, again, 2 arteries carry blood away from the fetus and 1 vein returns blood to fetus. I made it simple like that. That good?
Mm-hmm.
And then here's your Wharton's jelly that covers and cushions the cord vessels, like we talked about. And then again, the cord, umbilical cord usually protrudes right in the center of that placenta that I showed you. And here's a beautiful cord. Can you see here? Now, it's usually about 22 centimeters. Okay, now we have in the heart, there's shunting, okay, because it's a different setup than what you have in intrauterine circulatory system is different than extrauterine. Extrauterine is means that the baby's outside of mom's womb. So when baby is inside, blood is shunted in a different way. So the foramen ovale is the opening between the right and left atria, which is your upper chamber of the heart. There's an opening there, okay? Now, don't forget, after birth, all these will close, because then the blood will go to the lungs and from the heart to the lungs and vice versa, and things will be normal circulation. Now, the ductus arteriosus is a fetal artery that, you know, you have your aorta and you have the main lung artery. So you have to have some kind of connection between these two. And so this is called the ductus arteriosus. So this duct allows blood to detour away from the lungs because we don't need it till we're born. And so we have a difference, again, a different way of circulating blood, because baby needs blood to grow and to use and to have, because it carries oxygen. Now, your ductus venosus is a shunt that allows the oxygenated blood in the vein, remember, oxygenated blood is in that vein, to bypass the liver, because the liver is not you know, mature enough yet, and is essential for fetal circulation. So here's a little diagram of all that, so you can see. So here you got between the right and left atrium, and you have your umbilical vein. So that kind of gives you a little picture of what's happening. Now, again, this is before birth. So blood enters the fetal body through the umbilical vein, okay? Comes in through the vein. About half goes to the liver, okay? And the remainder goes through the inferior vena cava through the ductus venosa, okay? Okay, so here's your ductus venosa. Let's see, where is that? Let me see. Excuse me. Arterial duct, oval duct. Here it is, I guess, right in here. Here we go. And then you got your foramen valley through the ductus arteriosus. So you can just see here the difference here. See here? The right and left. Because you don't need it be going to any kind of the lungs or anything for circulation. So this is why you have these shunts. And the shunts do close after birth. All right. So here's your afterbirth. So that foramen valley that was between the right and left atrium, they close within 2 hours after birth. Okay. The ductus arteriosus closes within 15 hours of birth. Permanently in about 3 weeks. And your ductus venosus closes functionally when the cord is what? Cut. So that one, as soon as the cord is cut, baby is what? On his own. All right. Now, it's really neat because these shunts, you know, they close and then they become ligaments in the baby's body. All right, everybody good? A little different, but keep it simple. Just write your little notes as which one is oxygenated and which one is not. And just know that babies inside, they don't need the regular circulation that we have. They need to have different types. They just need from the heart to go through to the other organs. Okay, for growth. Okay, so intrauterine growth restricted babies. All right. This happens when you have reduced number of cells in organs. All right. Fetal growth. This is how we determine fetal growth, guys. It's best assessed when the weight, length of gestation, placental size, and the newborn head and abdominal circumference are considered. Fetal growth is limited by what is taken in by mom and oxygen received by mom. And then a healthy mother can produce a healthy child who's less to illness. Remember, a healthy mom equals healthy baby. Okay. All righty. And a woman who's undernourished in utero can result in permanent changes. What is folic acid? So why is folic acid so important? Anybody? Who's still with me? Hello.
I'm still with you.
Okay.
Yeah, I got it on mute because I got my boys.
Oh, okay. So what is folic
Yeah,
acid?
I got it on mute too.
Okay.
Folic, yeah.
You said why is folic acid important?
I know it's important.
Yeah, what are we trying to prevent?
Isn't it for surfactant? Like,
No.
Is it? Oh, I know why. It's because we're trying to. The fetal thing. It's not HCG, but it's a similar 3-letter thing where the fetus to be deformed and maybe dead or something.
All right. Well, we don't want. Okay. But so write this down, y'all. Folic acid is important for the mom to take in, especially during the embryonic development time, in order to significantly decrease the chance of an open neural tube defect.
Open. I should have known it. Why I remember that?
You got it?
Neural. You said neural defect?
Yes.
Tube defect.
So, such as spina bifida.
Yes.
That spina bifida, the meninges of the spinal column is outside of what? The baby. So the neural tube is, we want it to close during the embryonic time. We want that to close. So in order to get it to close, it's been shown that mom takes in 400 micrograms of folic acid, especially during the embryonic time. It significantly decreases the chances of that baby born with open neural tube defect. You got it?
Got it.
You got it?
Yes,
So
ma'am.
we can prevent. Hey guys, we can prevent. This was research that I remember it coming out. I was so excited. Just by taking folic acid, we're able to make sure that that neural tube closes. My goodness. Years ago, we used to have a lot of babies born with neural tube defects, such as spina bifida. Another bad defect is hydrocephalus. Very bad. So we really want to, during that embryonic time, we really want to encourage mom to take folic acid. That's why this is why I've always been on this preaching this, is we want to get these women in before they even get pregnant. That's my dream. That's the optimal dream, is to get the women in before they get pregnant. Okay. So remember that, because I'm sure you'll see that again. Okay, let's move on. Okay, so you were talking about twins and everything. So I think, Nicole, you were talking about that. So the monozygotic twins, remember mono is one, and there's your zygote. Remember we talked about the zygote. So when we have a zygote now that are they're called monozygotic twins. They're born from a single fertilized ovum. Remember the one ovum? Okay. Remember the ovum that comes up and then the sperm comes in. Okay, that's why these guys are identical. Okay. Now, the dizygotic. So di means two, and there's your di, the zygotic. Twins are from two separate fertilized ovumes. That ovum had a little bit extra, and so it's from two separate fertilized ovumes. Now, those are called fraternal twins. So you see twins more when, maybe she's taking some medication, especially in infertility patients, when they take drugs such as Clomid, to release more ovums, to release more eggs, and for the chances of getting pregnant. This is what happens, that you have the two eggs, and they both get fertilized. Okay. So I have a little film here, but I think for time I'm going to have to skip over it. But it's a good film on ovulation. Okay. All right. So let's go into chapter 4. You ready? All right. So chapter 4 is about prenatal care and the changes that occur during pregnancy. All right. So you know by now that antepartum is before birth, which is your prenatal time, right? That's what we've been talking about. Intrapartum is during birth, right? Okay. And then postpartum would be after. Post means after. Okay, you got it. All right. So what are our major goals? Well, you want these women to come in, and we discussed a lot of this already, but just ensure that mom is having good health habits and reduce risk factors. That's the main thing. Reduce the risk factors. You want to teach good health habits, and these health habits can continue throughout her entire life. And then you educate them in taking care of themselves. So it's called self-care. We're gonna watch them all the way through, make sure they take good care of themselves. Also, part of prenatal care is getting these parents ready for the responsibility of parenthood. And then again, you're developing a partnership with the parents, the family, because why? You want to ensure continuous and good health care. So those are your goals of prenatal care. Now, these are terms I'm sure you're already seen, right? So everybody knows that gravida is the pregnancy, number of pregnancies, A null gravida would be she's never pregnant. Null, never pregnant, because gravida member is pregnancy, so she's never been pregnant. Prima gravida just means that this is her first baby. Okay. Multigravida would be she has been pregnant at least more than 2 times. Okay, she's a multigravida. And so then para is the number of pregnancies like that have made it to 20 weeks, because that's viability, or greater. Okay. And then these are just terms that you've probably seen. Prima para, giving birth for the first time. I'm going to skip over here. We know about abortion, which is termination of a pregnancy. Gestational age is just how far along the pregnancy goes. 22 weeks gestation, 24 weeks gestation, just how far along the pregnancy is. We know fertilization is the time from the time that it's fertilized. It's fertilized in the ampulla of the fallopian tube, and we talked about viability already. Now, you're going to have a question on this, the GTPAL. This is part of the obstetrical history. So, gravida is how many times, what number of pregnancy? Now, guys, listen real carefully, okay? Do not forget, when you're reading the scenario, do not forget the present pregnancy. Okay, I think we just had a question on the quiz the other day, right? And so you want to make sure that you don't forget the present pregnancy. T would be how many babies made it to term. How many weeks is term? 37
weeks.
37, right? 37 to 40, right? Or 41, 42. 41 is post-term, right? Preterm. What weeks of gestation is preterm?
36.
Before.
Is from 20 weeks viability to 36 and 6 days, right? Okay.
Yeah.
Okay. Abortion, miscarriage.
If she loses the child anytime during the pregnancy.
Before
right?
20 weeks. Yeah.
Before 20 weeks.
Right. And then L is
Living children.
right. Good. Okay. So here I just have that down for you. I want to see if you knew it. So, oh yeah, you don't have your quiz yet, right?
Ma'am?
This week you didn't have your quiz yet, right? You didn't
Yeah.
have
I had the quiz.
oh, you
already.
did. So this
I
was on
did.
the quiz. Okay.
Yes.
Okay.
It's the key is the with the knowing the preterm and term, like you said,
Yeah.
the 36 weeks, I think, and then 37 weeks is term, right?
Right.
Yeah.
Yeah. That's the key. And tell you, because if you need to, you can always write out GTPAL, and then you just plug in your how many is in the scenario, what the scenario is telling you.
That's what I do.
Yeah, that's
As
what
I'll
you
put GTPAL like in a row, and
Yeah.
then like do little dots or like little
Right.
sticks every time.
Yes, exactly right. So this is what's important to know. These term 37 to 40, preterm. Well, this one says 24 to 36 and 6/7. An abortion would be anything below 20 weeks, which is viability, or miscarriages, and then live births. Now, what happens if she had a set of twins?
It's going to be the same gravida, but different living.
You got
on
it.
the L's.
I'm very proud of you. Very good. You got it. Okay, so let's go on here to the trimesters now. So you got the GTPAL. You got that. That's superb. Let me see if I got a question on that one. Let's see. I think you know that really good. If you were let's see. If you had a woman come into your clinic and she's pregnant for the first time, what gravida would she be?
Prima.
Yeah, okay, she's a prima. Yeah, you're right. So she'd be gravid of 1, right? And how many living children does she have?
1, none.
Zero.
None. You got it. Good. I'm so proud of you guys. You got it. Okay, so let's talk about real quick these trimesters. Remember, they're broken into 3 13-week parts. That's how we determine, because in each trimester, different things occur, right? And so it's good to know, like the beginning trimester, that's a trimester of ambivalence. And what else happens in the first trimester? She goes through surges of hormonal uterine growth, right? And she has nausea and vomiting a lot, right? Due to the surge of hormones. Then you go into your second trimester, and that would be from week 14 to what's the next one? 14 and 13 is 27, right? And then that's the time that the woman actually accepts the baby. What happens during the second trimester that she's able to connect with the fetus? Remember quickening? She feels the baby move. Quickening happens during that time. Okay. And then, and also the second trimester is called the honeymoon stage, just to let you know. Because it's a time that maybe now her nausea and vomiting are gone, okay? And now she's feeling good, and so now we can move on. Okay, and the third trimester, she's cooked. She's ready to what? She's ready to go. All right. Let's see here. We did a lot on this already, so I think we're pretty good on this. We got folic acid. Oh, talking about immunizations. Let's talk about rubella. Okay, rubella does it's a virus, right? And it does a lot of damage to a growing fetus. So every woman should be having the rubella vaccine, correct?
Yes.
Okay. If she's pregnant and you do a rubella titer and you find that she's not immune, what happens?
You can tell her that she can have the vaccine in the hospital after delivery.
You got it. You got it. Very good. Okay. You never give rubella vaccine during pregnancy. You never do that. Okay, good. Okay, good. You got it. Nicole, you got that?
Yes,
Okay.
ma'am.
Okay, good. Okay, so what is my role? I'm the nurse. What's my role during taking care of a woman prenatally? So I'm collecting the data from her. So I'm doing a surgical history. I'm doing a medical history. I'm doing obstetrical history. Okay. And the reason why we do the obstetrical history is because the care is going to be different. It's going to vary if this is her first baby versus this is her 5th baby. Okay. So that's why I want to know, how many babies did you have that reached term? How many babies were premature? Did you lose any babies? Okay. This is where you pick up a lot of information that you're going to base your plan of care on so that she has an optimal outcome. Okay. That's why you do that obstetrical history. Okay. So I got educating. I'm looking for risk factors such as what? Hypertension, diabetes. I'm also looking to make sure she's getting nutrition counseling, and then also promoting the family changes to the pregnancy. Okay, so here is a guideline. So these are your life schedule. So from conception to 28 weeks is usually every 4 weeks. Okay, all right. And then I can see, remember something very, very important, guys, is to get a baseline vital sign, baseline weight, okay? Make sure that, we get that, first ultrasound in about 10 weeks, okay? Because I'm looking for what? I'm looking for a positive sign of pregnancy which is the fetal heart rate. So you want to make sure that you get everything in early, so you got a good baseline. So when she comes back in, that you see that there's no big fluctuation in blood pressure. Okay, there's no big fluctuation in weight, because if she is having fluctuation in blood pressure, you know, it's about 20 weeks that the preeclampsia can come into play, which is the patient can get very, very sick. So can the baby. So therefore, I really want to keep a close eye on her. So we try to, work it where, she'll be compliant, come every 4 weeks in the beginning. Then as we grow into another trimester, we go from 29 weeks to 36 weeks, every 2 to 3 weeks. And then from 37 weeks to birth, we're going to see her weekly, because things can change a lot during that time. Now, if she presents at any time some risk factors, such as blood pressure going up, or baby's too big, maybe where the fundal height is way off where it should be, then we're going to maybe bring her back a little bit extra to see. All right. So, again, every patient is unique. So we taper things to their needs. Okay. Because, we want to make sure that we take care of mom and baby, and we prevent these low birth weight babies. Okay. So I think we went over this a lot already. We did this, Nagel's rule. Everybody knows how to calculate a due date using Nagel's rule. You count back.
Yes, ma'am.
Now, you take the first day of the last menstrual period. The first day. Okay, now some scenarios, some questions, especially on tests, they give you a scenario. They might give you the first day. They also might throw in a distractor, giving you the last day, So don't be thrown off when you see that. It's the first day of the last menstrual period. You're going to count back 3 months. Boom, boom, boom. Add 7 days to that first day, correct? So you got your month and you got your date. Okay. Now, I talked about the ultrasound at 10 weeks, because you're going to get a crown rump measurement, and that will actually give you a very accurate due date. Okay, so we do that. Also, this 10 weeks gestation ultrasound, you want to make sure that you see the heart rate, the heart beating, boom, 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 boom. Because if you don't have that, you could have a molar pregnancy, and you want to pick up the molar pregnancy early. Okay. We talked about obtaining our baseline. Okay. And here's our blood work. We're starting out with baseline here too. So we're going to test for HIV, CBC, rubella, here's your rubella titer, hepatitis, RPR, VDRL, and RH and blood type. Got to know the blood type. Why do I have to know the blood type?
For blood transfusions.
Well, I want to know
RH.
For the RH. Why do I need to know that RH?
Because if the mom is RH negative,
Yeah.
you might need to give her a Rogram.
That's right. Good. Exactly. Yeah. Right.
I've got I'm don't mean to get you off topic, but that last slide you were talking about the ultrasound at 10 weeks.
Yeah.
But I thought you were supposed to do the ultrasound at 20 weeks for a full anatomy scan.
Yes. So we usually do 2 ultrasounds.
Okay.
Okay. So we do one early in pregnancy. She could be 8 to 10 weeks. Because you want to confirm there is a pregnancy with a heartbeat.
Gotcha.
Okay. Because she could have molar pregnancy. That molar pregnancy does secrete HCG.
Okay.
And so, she thinks, a person can think I'm pregnant, But if you don't have a heartbeat, there's no fetus. There's nothing. You have is a very serious condition called hydeniform mold. So you want to make sure you get an ultrasound to confirm, because that's a positive sign of pregnancy, is the confirmation of the heartbeat.
Okay.
Okay.
So, yeah, on a routine pregnancy, it's usually 2 ultrasounds.
Right. It's not, it's not routine. It doesn't occur at every visit. No. It occurs at 10 weeks and 20 weeks, and that's it.
Okay.
And the reason for 20 weeks is to see the baby's anatomy, make sure that everything is there.
Gotcha. Thank you.
You're welcome. Okay, so I'm going to skip down here. These are just routine assessments of each prenatal visit that we're looking at. You got your risk factors, vital signs and weight, your analysis, blood work, bundle height. We can do a lever pose maneuver. That's just taking our hands and assessing if the head is down in the pelvis, or is she breech. So we're looking for presentation or position of the baby. The fetal heart rate is 110 to 160, okay? And nutrition intake. We're looking to see, what's she eating, because we want to do what? For fetal growth. Okay. Now, again, we increase calories during the antepartum time by 300 calories. You increase protein by 30 grams per day, and there's your iron, and there's your folic acid. Now, a lot of ladies don't get enough iron through their diet, okay? So sometimes we have to give them a supplement if their hemoglobin hematocrit is kind of low. So, but ladies don't like to take iron because it has a tendency to constipate. Okay, so this is kind of like a little battle here sometimes, getting them to take the iron. And then they have to take in vitamin A, vitamin C, and calcium through their diet. Okay, and then of course they should drink water, at least 8 to 10 glasses of fluid per day. That's also a battle, because they say, I go to the bathroom enough, I don't want to go more to the bathroom. Okay, we already did Nagel's rule, so we're good on that. And let's see, diagnosis of pregnancy. This is your definite signs of pregnancy. You can guarantee there'll be one of these on there. So remember, what is presumptive signs? Presumptive signs is what the woman is feeling. See that what she's feeling, what you're feeling. So amenorrhea, nausea. Should they come in and say, oh, nurse, I'm nausea, my breasts hurt, or, I'm feeling some changes in my skin, and, I think I feel a baby moving even. That's presumptive. All these signs could be something else. She could have gas. Instead of quickening of the baby, it could be gas. She could have urinary frequency, it could be UTI. Breast tenderness, well, you get that when you have your periods. Nausea, she could have a stomach flu. Do you see what I mean? Amenorrhea, she could have what? She could be stressed out. Maybe she's taking a nursing test. So she could have these things, but not guarantee she's pregnant. That's why we call it a presumptive sign. Make sense? Anybody? Make sense? Okay.
Yes. Yeah.
Okay. Yeah. Now the probable is what the examiner sees.
Yes.
Mm-hmm.
Probable. So like the Cradell sign, the softening, the Chadwick sign. Chadwick is a purplish, bluish changes that we see on the cervix. These are what, again, somebody else, the examiner has to see. Okay, they're probable. Okay,
and a positive pregnancy test too, right? Is under the probable.
Yeah, I would put probable. It's not positive, right?
Yeah. Say that again. Like
The pregnancy test, it could be equivocal, unless you're having a serum HCG, it could be off. It's again a probable. The examiner sees it, that's probable. You feel it, or the woman feels it, that's presumptive. Okay. All right. Now, positive. Hey guys, it's positive. I swear I do an ultrasound and there's the fetus. It's plain as day. It's there. I listen to fetal heart rate. It's there. I hear the fetal heart rate. I hear it. Okay. These are very positive signs. You can't get around it. Like, for instance, let me tell you a quick story. I was called down to the ER because this young girl, she was like 14, and they were working her up for appendicitis and all this. And all of a sudden, she started screaming. Okay. Well, they realized that she probably had a baby, having a baby. So what they did was they called me down from labor and delivery. I ran down with my precipitous delivery kit, and she's yelling, "I'm not pregnant. I'm not pregnant. Mom, I'm not pregnant." I'm there and I say, "Okay." I'm looking and I see a head crowning. All right. So I said to her, "Okay, you can say anything you want, but do me a favor, just push this baby out, because this is a real positive sign that you're pregnant."
Wow.
And I delivered the baby. So that is a positive sign. So you see the difference between the presumptive, the probable, and the positive?
Yes.
Okay, Nicole, you see that
Yes,
difference?
ma'am. Yes.
Good. Okay.
Yes, ma'am.
All right, it makes sense.
I'm listening. It's hard to tap back into it to get to you. I'm like, have you on mute because everybody's
Okay.
home.
That's okay. So these again,
Same here.
I got you. So the presumptive signs of pregnancy again, here you go. Here's another slide. And again, these are all what the woman feels. Okay. And here's your quickening. All right. Now, this is probable. I went over the Goodell sign, which is the softening of the vagina. The Chadwick sign, that's the bluish, purplish discoloration of the cervix, because it is very vascular area. And then you have the Hager sign, which is softening of the lower uterine segment, and the McDonald sign. This is where the uterus is flexing against the cervix. That's again, but these are evidenced by the examiner. Okay, and then we got our positive sign. And when you see this, that's pretty positive. Okay, I guess I felt that students had a hard time with this, but you guys are doing great. You got it down packed, so we're just gonna move on. So what happens to a woman's body during pregnancy? Well, she does have changes in her body system. One is the endocrine. Okay. Remember, the placenta is a temporary endocrine organ. It produces a large amounts of estrogen and progesterone to maintain the pregnancy. We went over that. Okay. It also produces the HPL, which is the human placental glycogen. So again, it has significance on blood sugar. The reproductive, we talked about the uterus. It changes from a simple little pear-shaped organ to a temporary abdominal organ. Okay. Now at term, when she's 40 weeks gestation, the uterus is going to be up around her xiphoid process. It gets pretty high because don't forget, you have the placenta, you have the fetus, you have the amniotic fluid, and that comes about to be about 5,000 mLs of fluid. That is a lot. Okay. And that's why she has a harder time, maybe with breathing, is because the uterus is now pushing all her abdominal organs up higher. That's why sometimes when you get to be term, you don't enjoy eating as much. You can't eat that big old meal that you want to eat all the time like you normally could, is because you get a lot of heartburn, because again, everything is displaced. Respirations become deeper because you have increased oxygen consumption. Okay, it increased about 15%. Your cardiovascular, because during pregnancy, you have increased cardiac output. It increases like 45 to 50%. That's a lot of extra blood volume. Okay, so all this blood is being pumped from the heart. So the pulse rate can go up around 10 to 15 beats a minute. She's got all this more circulating. She's working really hard. Her cardiovascular system works very hard. And if she has any kind of defect, or she's had a history of cardiac problems, she's going to feel it during pregnancy. We talk about the GI again, because the stomach now is displaced. And they kind of, the stomach and the intestines kind of shoved toward the back. Because don't forget, there's only so much room for this, and she has a big baby, a macrosomic baby. It really displaces the intestines. If she has twins or triplets or quads, they also have problems with this. So we have to watch them very closely. And urinary, again, the system excretes the waste products for both the mother and the fetus during pregnancy. So therefore, she goes to the bathroom more, okay? And so all this she has to adapt to all these. She gets these stretch marks. They're called stridate gravidarum. These are stretch marks. Of course, the skin is going to stretch, okay? When it stretches really quickly, when she gains like a lot of weight on the uterus, there's a big growth, then the skin stretches quickly. It has to give, so it's going to have these stretch marks in order to accommodate. So they don't ever go, they fade after pregnancy, but they never go away. And as you get older, when you get about 60 years old, Nicole, your stretch marks, if you have any, will turn silver. Okay. Then safety education is vital to
What? It turns silver?
you turn silver. I thought I thought I was gonna get your attention. Yeah, so let's just let you know. Safety
Oh
education.
no.
Oh yes, it's okay. By the time you turn 60 or 70, you won't it won't matter anymore.
Right.
And of course, safety, guys. You know, as she changes and has this big old belly, she gets that waddling gait. Remember, that's because you have relaxed pelvic joint relaxation of the pelvic joint.
Yeah.
So you know, you have to make sure that her balance is more, you know, she's not off balance, because she could fall. If she falls, her tummy could hit, and she could get a bruchio placenta because she has some trauma to her stomach. So you have to make sure you think of safety on all during pregnancy, because you know, it can be affected very easily. Now, with stairs, going up those set of stairs, I always tell my patients, you may get out of breath, just take a few minutes, catch your breath, and then resume. Okay. Getting in and out of the bathroom. You might want, I tell them, always have somebody in the house with you so they can help you get in and out of a shower or a bathtub. Because again, these are areas that person can get a lot of damage to their body, especially in pregnancy. Her tummy hit something, she could have abruption, placenta abruption. Okay. All righty. I think we talked about this already about the temporary endocrine organ, so I'm just going to skip over that. And we talked about the uterus. Okay. We talked about mucus plug, prevents the growth bacteria. We talked about the ovaries. We really did a lot of discussion on that already. Here it shows you how the uterus does change. Remember, you know, the fundus was the top portion of the uterus. So here's your top portion of the uterus. This is your fundal area. And then you can see how high up it is. Okay, at 40 weeks, it's right there with the xiphoid process. So there's only so much room. The ribs do stretch out. Okay, it's amazing. The hormone relaxin has major part. Let's see here. Here's your umbilicus. So usually at 20 weeks gestation, she's measuring, if she's 20 weeks gestation, she should be 20 centimeters in the fundal. So remember the symphysis pubis we talked about earlier? So you take your tape measure, here's the tape measure, you put it at the symphysis pubis, and then you take your tape measure and just bring it straight up. And here's the linea negra we talked about. And then the practitioner comes right up to the fundus of the uterus and says, okay, this woman looks almost like she's due. She's about 38 weeks here. Okay, you can see the striae gravidarum. These are the stretch marks right in here. She got a lot of stretch marks. So she must have had a big baby or she had a lot of growth. Okay, so that's how we measure. And you know, the significance of doing this is that we can tell if if the baby is growing too fast. Okay. Hold on just a moment. Oh dear. Amber alert. Okay. All right. Everything's good. Okay. So if the baby is growing too fast, then she would not be measuring correctly. So say she's supposed to be measuring 26 weeks. And when we measure her, she's measuring 30 weeks. That's a big baby, okay? Because if they're not even, they should be even. They should be matching each other. The same thing if she's not getting enough nutrients, the measurement could be less than gestational age. And then we know what is going on inside. Is she not eating properly? The baby's not growing like we want it to grow. And so then we would follow up with an ultrasound. Does that make sense? Okay. All righty. So now, okay, so now we got the effects of pregnancy on the respiratory system. So like I said already, the oxygen consumption by 15%. We talked about this estrogen, remember, it's a stimulant. So basically it increases the edema and swelling of the mucous membranes of the nose and nosebleeds. And nasal stuffiness. I've seen that on questions. Estrogen is the one that does that, okay? Estrogen is the nasal stuffiness and voice changes. We talked about the cardiovascular system, how it increases. Because don't forget, mom has to supply the baby, okay? So you're going to have exchange of nutrients, oxygen, and waste products within the placenta. So that goes all hand in hand. So that's why she needs her blood volume increases so significantly. Okay, and two, that's why when you deliver, a woman delivers, she loses a lot of blood. Okay, because everything is very, very blood enriched, I should say. So fetus needs it, mom needs it, so she needs it. So that's why she can take all that blood loss at birth. And again, like I said before, her pulse does increase 10 to 15 beats. Okay. We talked about the increase in circulatory volume. So we got that. Let's discuss a little bit of supine hypotension syndrome. So do you put a woman laying on her back in a supine position?
No, not a pregnant woman.
Right. You always put them on their side. Okay. Because if you have her on her back, what happens?
She
the spinal cord for the baby, like.
Now,
so
what happens
it could
to
press
mom
on it.
if you put a lady on her back?
Or she could have supine hypertension.
Right. So what does that mean? Hypotension. What happens to mom?
Her blood pressure drops. She
Drops.
can become dizzy.
Dizzy,
Right.
faint,
Right.
fainty.
Exactly. Right. When somebody's blood pressure bottoms out, when they go down, they're gonna get fainty, lightheaded, dizziness, sure. And because it's not a nice feeling to feel that way, they can get very agitated. Okay. So what are you going to do in order that you don't have this supine hypotension syndrome?
Put her on her side.
Right. Put her on her side. And I'm going to tell you, preferably the left side, because you get more placenta perfusion, more blood perfusion when she's laying it on her left side. Okay, good. And here's just another drawing of what happens. Don't forget, now when she's in labor, you want to labor her on her side also, because here you can see how the uterus during contraction puts a lot of pressure on the uterus and on the baby and on her back. on her heart, her inferior vena cava. Okay, good. Can you see how one thing does affect the other? So you have this hypotension, you have palpitations. You could have what we call pseudo anemia, which means that it's truly not anemia, but it's dilution. The blood is so much blood volume going on that the blood becomes thinner, per se. It gets more diluted. So it looks like she's got some kind of anemia because the blood is what? Thinner, okay? But so that's pseudoanemia. And then she does have an increase in the second and third trimesters of increased clotting factors. So you have to worry about like a DVT, a thrombophlebitis. So like when she travels, you have to worry about that. Okay. Now you have effects on the pregnancy of the GI. I think we talked about this. What is pica? P-I-C-A. What's
That's when
PIC? Go ahead.
eating stuff like, cornstarch, flour,
Yes.
clay.
Anything that's not food substance, right?
Yes, ma'am.
Okay. Now, what's the nurse's role in dealing with somebody who is taking in, like maybe soil or chalk, or something like that?
I would think they're anemic. The patient is anemic. I'll probably do a blood workup.
Okay. Also, what's also important that the nurse should know?
What they're eating.
Yeah. How about how much of it?
Oh,
How
okay.
much of it they ate?
Yeah. We know if somebody tells you that, okay, I'm a patient, I come into your clinic and I say, yes, I'm craving, like, I have these strange cravings for like chalk. And you go, okay, I've heard of that. That's called pica. That's normal. But being a nurse, I would want to know how much of that are you eating,
Yeah.
right? Yeah. So that's where that comes in. We don't ever, in nursing, we don't ever judge somebody because we know that's normal. We just want to know, like, how much of this stuff are you eating? Okay. And that's where that comes in. Okay. This just shows you how the body changes. She adapts to her pregnancy. You can see here's your uterus, and look up here. Here's the uterus. So you can see here. Now here's all her intestines, her large intestines, and everything's nice. Everything's in place, correct? Now you see how the baby develops and has become a more determined baby. Okay, where's the intestines now? They're pushed up into the back. Where's your stomach? Where's your liver? See how it all changes?
Mm-hmm.
She has to adapt quite a bit. Okay. All righty. This one goes over the urinary system. Just take note to women are more susceptible to UTIs. Okay. Again, progesterone that we needed to maintain this pregnancy also causes the renal pelvis and the ureters to lose some tone. So that's why sometimes she goes to the bathroom a lot, and sometimes it can retain some of that urine. We call that urinary stasis. And when that stays in the bladder, doesn't get released, right? It can cause a UTI bacteria. Okay. So just, the progesterone, again, these things affect these different systems. This is a little guidance here on weight. So if the question says she's of normal height, so how much would you tell her to gain? She was of normal height. How much normal weight should she gain?
25 to 35.
25 to 35.
Right.
pounds.
So that's how those questions would be asked. They would tell you if she was overweight, what should your guidance be for that?
11 to 25, it says.
Right. And if she was obese weight, morbidly obese, she's
11 to 15.
Right, exactly. So that's how those questions are asked. So, just kind of keep in mind the different scales, but normally they usually use this, the normal weight gain. Okay. We already talked about pica. Just know something, that when a woman is breastfeeding, they are able to increase their calorie intake by 500 calories. Write that down, because you might see that one again.
Repeat that, what you said?
Yeah.
When,
Okay, so when a woman is breastfeeding, okay, she's able to have 500 calories more. So
even if she's pumping,
yeah,
like
yeah,
just pumping.
yeah, she's breastfeeding, right? She's pumping,
Mhm.
right? So she can have 500 calories. This is how a lot of times I get women to breastfeed, because a lot of times I advocate for that, but a lot of times they'll say, "Oh, that's just too demanding. I don't want to do that." Well, I'll say,
I just do that by looking.
you can have 500 calories more. Oh, okay. That sounds good. I like that. Also, I have these young patients who just had a baby. And I said, you want to get back in your skinny jeans real quick? You go ahead and breastfeed, and because the involution process is quicker when they're breastfeeding. Okay. All right. So we went over the vitamins and all things. Exercise, hitting upon it quickly. You want to maintain fitness, okay? Pregnancy is not the time to start like a marathon, running a marathon. It's not this time to start lifting heavy weights. No. It's just maintaining. So the rule of thumb is, if you didn't do it before you got pregnant, you're not going to start while you're pregnant, all right? But everybody can walk. So I usually tell my patients, get out every day and walk either early in the morning or in the evening, especially if you live in the South, because I don't want them to get overheated. Travel, always a question on travel. So they can travel during pregnancy. They can travel up to 36 weeks. Write that down, 36 weeks gestation, okay? The main thing is they need to avoid sitting for an extended period of time. Remember, the second and third trimester, you have an increase in clotting factors. So therefore, if they're traveling and they're still like 34 weeks, okay, they could get a DVT very easily. So you want them to get up and walk around the plane, up and down the aisle. You see that a lot more too, even with regular people. Some people get up and do walk so that they're not sitting for a long time. The main thing is you want to avoid locations that put you at risk for an infectious diseases. You don't want to get infectious disease during pregnancy. And also bring a copy of your obstetrical records, because you might be going to another state. And if you go into preterm labor, you need to have your blood type and all that information, because you don't want to repeat it again. Also, they should be drinking 8 to 10 glasses of water a day. Make sure they have good oral hydration. All right. This is just a slide that goes over different discomforts in pregnancy. We talked about fatigue, hormonal changes, nasal stuffiness. We talked about this, constipation. Okay, if they're constipated, we don't want women constipated, right? Because if I've had women come in where they didn't have their cervix wasn't dilated, but they were like feeling like they were in labor. It's because it was due to constipation. So too much stool in their colon there would cause them to go into have contractions. Okay, hemorrhoids are never fun. They are varicosities in the anal area and cause a lot of discomfort for the patient. And then during labor, you'll find out they even blossom some more. So hemorrhoids are never good. You want to make sure that she has increased fiber in her diet, and good in fruits and vegetables, and also water. Remember, we went back to that water again. She needs to be drinking lots of water during the pregnancy. Alrighty, let's go on here. Oh, fatherhood. There's always a question on this. So you got fatherhood, you had the different, let me see here. Excuse me. The different little phases of fatherhood, you know, the announcement time when the pregnancy is confirmed. No, they get excited. They have, they go through acceptance, accepting the pregnancy, which results in strengthening of the family. They go through adjustment. Now, adjustment time is the second developmental stage of fatherhood, right? So during this time, the father may plan financially, become involved in playing the baby's room, actively listening to the fetal heartbeat, you know, and just touching her tummy. That's a nice adjustment time. And the focus is they make active plans for participating in labor, birth, and process. There's always a question on exam for that. All right. Impact of the adolescent. What do you think about the adolescent time? The adolescent time is a time where they go there, you know, they're not even mature and they have a teenage pregnancy. It causes a lot of what? Stress. And stress can affect the hormones. It can have a definite effect on pregnancy. All righty. I think you wrote on discussion 2, you had to write a paper on adolescent pregnancy, right? Yeah, so
yes.
Yeah, you
Yes,
went
ma'am.
through, yeah, you went through that. Okay, good. All right. And then you have the impact of the single mom. Again, it could be an adolescent or it could be a mature woman, but it's not easy. They do have unique emotional needs. Single women who plan pregnancies, they're often prepared for financial and lifestyle changes where the adolescent doesn't. Okay. So again, all these different categories have different needs. They all have different needs. These about immunization and pregnancy. Rubella is your biggest one. You don't want to give during pregnancy. They always have a question on that. And then we already went over when is a good time if they are pregnant. I think Alan, you said a couple hours ago, you said that they can give it after delivery, right?
Yes.
Before they go home. Then we know they're done. They can breastfeed when they, even though they get a rubella vaccine after delivery, they can breastfeed. Do okay. The main thing I want you to remember is you do never give a live virus to a woman who is pregnant. Okay, never, never, never. Okay. All righty. Let's see here. Are you still okay? Well, I'm going to go into chapter 5. This is our last go around. I think we got a few more slides, but let's go ahead to chapter 5. That's this week. So, I would definitely look over danger signs in pregnancy. Okay, these are signs that happen that are not good. Okay, so you have a sudden gush of fluid from the vagina. That would be your bag of water breaking. Okay, vaginal bleeding is not good. Remember, we talked about first trimester being she's miscarrying. If she has vaginal bleeding late in pregnancy, that could be placenta previa or abruptio placentae. That is not good when you have vaginal bleeding. Abdominal pain, again, is not good. It could be that she is having maybe problems with her gallbladder. She could be having contractions. If she has epigastric pain, like right here, I have it right here. That's not a good. That goes along with preeclampsia. That's escalating. That's getting worse. So epigastric pain, persistent vomiting, not good. You have in the beginning of pregnancy for the first 13 weeks, you have the nausea and vomiting normally in pregnancy because due to hormonal changes such as progesterone. But persistent vomiting is not good. You know, we worry about hyperemesis gravidera. And then you have edema of the face and hands. That'll go on preeclampsia, not good to see that happening. Severe persistent headache. This is a headache, guys, that is not relieved by taking in Tylenol. This is persistent, severe headache. That's very indicative of hypertension, and that can be related to preeclampsia. Blurred vision or dizziness, again, not good. It can go along with preeclampsia. Having a fever, she could have chorioamnionitis. Okay, patient has a fever, not good. And of course, painful urination or reduced urine output, not good. Could be she has a UTI, cystitis, or worse, traveling to the kidneys would cause you to have polynephritis. Not good. Okay. So what kind, if I have a high-risk pregnancy and I have a woman who's over 35, she wants to know the chromosomal analysis of her baby. She can have it through this test called an amniocentesis. So here you have a bag of waters, the amniotic fluid, and you take.
You said the sex of her baby. I'm sorry, Professor Durham.
Yeah,
sex of her baby through.
She wants
okay.
to know, like, she's aged over 35, so you a mature woman, advanced maternal age. They're always concerned about chromosome analysis. So they want to make sure that the fetus is okay. Yes, they can have a test, and it's called an amniocentesis. What they're doing is they're going into the amniotic cavity by a long spinal needle. See the spinal needle? And we're going in and getting fluid. Okay, so we're going to withdraw some fluid from this sac. Now, it does come with risk factors. Okay, she could go into labor, she could have a miscarriage, she could start bleeding, the baby could die. So it's a risk. But we do this test under ultrasound guidance. That means somebody else in the room and they got an ultrasound of her stomach, and they're guiding the partition. It's done by the obstetrician, and he's going to go into these pockets of fluid and just get out some of the amniotic fluid. Now that we sent off to the pathologist, the geneticists, I should say, and they're going to do the chromosomal analysis, and that will let this woman know if the baby is normal or is abnormal. Okay, so that's an amniocentesis. Again, it's used for genetic diagnosis in the very beginning of the first trimester. And usually, now don't forget, this test has to be done in the first trimester, but you have to wait till like week 10 to 12 weeks. Well, first of all, it has to be that you can be able to it's not inside the pelvis. The uterus is now in the abdomen. So usually by 10 weeks, you see the uterus coming out of the pelvis and into the abdomen, because you got to be able to visualize it. Also, don't forget, the bag of water has to have amniotic fluid. So you have to wait a little longer in order to have this test, because you need to have some amniotic fluid in there to be able to get some of it. So you can't have it in the very beginning of pregnancy, but you can have it around 10 to 12 weeks or 12 to 13. Okay. All right. So these are some of the complications. And we've kind of touched upon some of them. Hyperemesis gravidarum, persistent vomiting in pregnancy. This hyperemesis, write a note, it goes all the way through to the end of pregnancy. It doesn't let up. Okay. So this one does present a problem for the patient, for nutrition wise and for baby growing. Okay, we'll go over that real quick. Bleeding disorders, hypertension, and blood incompatibility. So here again, what happens with the hyperemesis that you have to worry about is the electrolyte imbalance. Okay, don't forget her electrolytes could be way off: sodium chloride, potassium. Decrease in potassium could put her heart to not to beat normally. So you got that problem. So you got to correct the dehydration and electrolyte imbalance. The drugs we use, Reglan and Sofran. Okay, so what you're doing here is trying to get her through to 40 weeks, close to 40 weeks as you can, because this lady will vomit all the way through her pregnancy. And don't forget, these fetuses need mom. They need mom's blood, oxygen, and nutrients. When you have everything that's reduced, it's reduced to the fetus. So it can impact fetal growth. Okay. So that's hyperemesis gravidarum. Okay. Now, your types of abortion are right here. So remember, these are bleeding disorders of early pregnancy, early. So these are the first trimester. So what happens is that they have spontaneous ones. So here you see a thread in day B. So you can see here that she's having a little bit of bleeding, okay? She may have a little bit of backache, all right? So the baby's still intact. It's just a thread. So what you can do is that you put her to bed rest, okay? Bed rest and nothing in the vagina for at least 2 weeks and let this settle down, all right? This, she can make it through, okay? That's just a thread in abortion. Now, if she loses the bag of water, and see how the cervix is dilated and the bag of water now is the membranes are coming through, everything's ruptured, we cannot stop this. So there's an inevitable abortion. Everything is going to happen. There's nothing I can do to fix this, okay? It's sad, very sad. And this one here is called incomplete abortion. You can see that she's already gotten rid of the embryonic tissue, as you can see here, but it's not complete. She didn't get rid of everything. So we have to do it, probably go in, take her for surgery. So you keep her NPO and you take her in for a dilatation and curettage. And we go in there and we'll evacuate the contents of the uterus. All right. And what happens that whatever came out, we call that the products of conception. Okay. And then we send that tissue off to pathology to go ahead and to confirm it. So this is where you have bleeding disorders of early pregnancy. And that's when you want to know, that's why that obstetrical history, I want to know how many times if she had a miscarriage, okay, that she couldn't hold a pregnancy, because that gives me a clue that maybe she has a decrease, she has a low progesterone level. Okay, now, whenever you're looking at bleeding disorders, you're always going to document the amount and character of the bleeding, okay, because you want to do a pad count. You want to save anything that looks like a clot or a tissue. And we always have it examined by the pathologist to confirm that it was the product of conception. And then you, like I said, you keep her NPO in case you have to do it, dilatation and curettage. Excuse me. All right. So that's your early bleeding. Now, another problem you have in pregnancy could be ectopic. We kind of talked about that before when we talk about the fallopian tubes. Remember, the fertilization happens with the fallopian tube, and that little zygote is supposed to travel through the fallopian tube, right? But it gets stuck. It doesn't go through. Something's in the way. Maybe there's scarring. There's maybe some adhesions in her tube. So the baby doesn't know, the little zygote doesn't know to stop growing. It continues to multiply. Well, it causes the pregnancy to keep growing, but it doesn't get into the uterus. It's not viable, guys. So what happens? She has tremendous right lower quadrant pain. And you must recognize that quickly as a nurse, so she can get to the hospital. And if they confirm it fast, early,
Hey,
she can save her tube. But if Alan, go ahead and mute yourself.
Sorry.
That's okay. But if she continues to grow and she doesn't get to the hospital, it can rupture. And when it ruptures, she loses the entire tube. Okay, so here are some sites for ectopic pregnancy. So this is what I'm talking about. So you've got here's your ovary, here's your follicles, here's your oocyte. Okay, now it gets fertilized up in the ampulla, and now it's going to keep dividing, okay? But it doesn't get through. It doesn't make its way to the uterus where it should be. It stays stuck, and it just keeps cell dividing. And that's why she can lose a tube if it ruptures. So that's why you want to, if you're on triage and a woman calls in and she's saying, I'm having right lower quadrant pain, it's really painful, really. The next question out of your mouth should be, when was your last menstrual period? She says 8 weeks or 6 weeks, and she's having that kind of pain. The thing you think about is ectopic. The sooner she gets to the hospital, the sooner she can receive methotrexate, which will target the ectopic wherever it is and break it up, and she'll get rid of it. Okay. But if she doesn't get to the hospital and get methotrexate, then it will rupture in this tube. She'll be very, very sick, and she'll lose the entire tube, which is not good. Now, this was just showing you different common sites for ectopics. They can go anywhere. I mean, here you got this free floating. This one went all the way down to the cervix, which is not normal. So you want to get it as soon as possible. 95% of ectopics occur in the fallopian tube. All right. So this was just a slide that I just went over with you. This is a slide on hypovolemic shock. So if you don't get your patient to the hospital and she has a ruptured ectopic, she can go into hypovolemic shock. Now, shock is shock, guys. So it's either you're in med surg studying about different, hypovolemia problems. They go into hypovolemic shock. That means they have a low blood volume. So they're going to have a weak pulse, okay, but rising. So when you see the shows on TV, they go, oh, it's 130 but weak. That's what they're talking about is tachycardia. Their respiratory rate, because the body is sensing something wrong, the respiratory rate will go up. It's called tachypnea. Their breathing is so shallow and irregular and so fast that it looks like they're breathing in and out real quick. That's called air hunger. Okay. And so you have all this going on. So the body, the heart is sensing that it's not getting enough blood. So it's going to decrease the blood pressure. You get hypotension. So when you have hypotension and you have tachycardia and tachypnea, your patient is in shock. It's called hypovolemic shock, low blood volume shock. And then, of course, blood goes to the major vital organs like your heart and lungs. The kidneys, the blood is shunted elsewhere. You have decreased or absent urinary output. Remember, when you have a patient who has less than 30 mLs per hour, you've got a problem, okay? You've got decreased urinary output or absent. And then your patient is in hypovolemic shock. You may look pale, mucous membranes are pale, skin is cold and clammy. And by that time, we're in pretty bad shape, but we already recognize hypovolemic shock when we have all this going on. Now, when you're pregnant and having this, the fetus is also going to be affected. You probably figured that out. So you're going to have a decrease in monitoring fetal heart rate. Sometimes it can compensate, go really tachycardia first, like over 160, and then go back down to decrease down to 90, which is not normal. Okay. All right, we talked about hydiniform mold already. We talked about the 10-week ultrasound. This is where it comes into play. It's called a molar pregnancy or gestational trophoblastic disease. Okay, again, there's all this chronic chorionic villi, all these things are developing. Remember, we had all that cell division going on, multiplication. Guys, it's really bad. Okay, there's no heartbeat at 10 weeks. There's just cells. We got a molar pregnancy. Molar pregnancy, she's secreting a lot of that HCG, a whole bunch. So her levels go very high. And then you have to take her to surgery. You're going to have to do a dilatation curettage. You got to clean out the entire uterus so that if she has to wait a whole year before she can get pregnant again. A whole year. She has to wait to get pregnant. Okay, and also later in life, she's more prone, she's at risk for developing cancer. So is it good? Never good. No. So this is what it manifests as your uterus grows a lot faster because it's just a bunch of cells in there. You don't detect fetal heart rate activity. She may have persistent vomiting again, which is never a good thing. She could have even gestational hypertension. Her blood pressure probably up. She has a memory levels of HCG are really high. And what happens is that it looks like just a bunch of cells together. It's like a snowstorm pattern on the ultrasound, and there's no evidence of a fetus. There's no heartbeat, and that's why we do those 10-week ultrasounds. Okay, so that's never good. That's a bad complication, and that causes a lot of grieving to women who got pregnant and didn't have a baby. There's no baby. Okay, now we had early pregnancy, which was your spontaneous abortions and miscarriages. We had the molar pregnancy. Now we have disorders of late pregnancy. And this is bleeding that occurs after 20 weeks. And this one is called placenta previa. A previa is just an abnormal implantation of the placenta. So where the placenta should be in the upper portion of the uterus, it should now be down by the cervix. This placenta previa lies, like if it's complete, lies strictly over the cervix, okay? That's bright red bleeding because it's right there, right over the cervix. So it's gonna be bright because it's fresh. It occurs, the bleeding occurs when the cervix starts to open up a little bit. And what I want you to remember is painless bleeding. So write down placenta previa equals painless bleeding. So you have marginal and you have complete. These are kind of old terms, but you have marginal, complete. Complete means it's just right over the cervix. That internal os, remember we talked about anatomy earlier today? It's right over the os. Marginal, it's like the placenta now is laying like 2.5 centimeters from the internal os, so it's marginal. These patients have to have C-sections. There's no doubt about it, okay? So here's a picture of what I was talking about for the previa. So here's the placenta. See how it's laying over the os? That's never good. And then when it lays all over the os, that's complete. This is like a marginal here. So you can see. So if you can see she's having bright red bleeding because it doesn't have a long way to go. It's fresh. So the cervix opens up, she starts to bleed. Write this down. You do not want this patient to contract. Okay? When she has a contraction, it would cause this bleeding to get even worse. So these kind of patients cannot go into labor, cannot have contractions, and they will be sectioned because there's no way you can deliver a baby where the placenta is. And you saw the pictures of the placenta, so you can kind of get a picture of, my gosh, you could, no way. Okay. So that is placenta previa. Painless, bright red bleeding. Okay. Now we have another disorder of late pregnancy, and it's called abruptio placentae. Okay. Abruption. So let me show you a picture. So here's the placenta and here's your hemorrhage. See here? The placenta should be adhered to the endometrium. It shouldn't be having this space here. This should be here. Okay, so it's abrupting. So it's coming off the wall of the uterus and it's having this dark red bleeding because by the time it comes down here, you see dark red, okay? It's a lot of blood, okay? This is an obstetrical emergency. This is where you have to get the baby out very quickly because the baby, again, remember, needs the blood from through the placenta. And this is not going to give the baby what it needs. So you're going to have a baby who's going to be in jeopardy. So abruptio placentae is not good. You have pain with this. It's very painful. Just think something abrupting. Anything abrupting would cause pain. So you got pain and her abdomen, her tummy changes shape, okay? And it's very rigid and it's hard. It's like a board. So that's placenta abruption. Okay. So again, it's not, it's something that, breaks away from the endometrium. So here it is. And you have a problem with the placenta, okay? It's just never good. Dark bleeding with pain. Okay, so here I put it together. These are complication of risk. So placenta previa, where the placenta is covering the internal os, you can have an infection because of vaginal bacteria can get up there. This patient with a placenta previa, now you're going to section her, do a C-section, but you have to worry about postpartum hemorrhage because that lower segment of that uterus where the side was attached, there are fewer muscle fibers. So the contractions of the uterus will be weaker. And when you get into postpartum, you'll probably go over that a little bit more, but that's placenta previa. Now, abruptia, these are things that are predisposing factors, such as hypertension can cause that placenta to break off. Cocaine absolutely causes that uterus, that causes that bleeding between the uterus and the placenta. So that, yes, you can have abruption. Cigarette smoking, absolutely. Poor nutrition. She could, maybe she has a blow to the abdomen. Maybe she got punched in the stomach. There's some trauma that happened. And then if a woman has a prior history, remember that obstetrical history I talked about earlier, it's always great to have a discussion if she had any kind of bleeding, of late pregnancy bleeding, and what kind it was, so that you have an idea that she might happen again. And then, of course, folic deficiency would also cause, again, abruptio placentae. Not a good situation. So pain is an important symptom that actually distinguishes abruptio placentae from placenta previa. So abruption, something that abrupts is pain, has pain. Okay. Her stomach is like a board, okay? It's real tight. It's painful. You touch her stomach and she probably will come off the table. Now, placenta previa, on the other hand, is painless, okay, bright red bleed. All right, so you got the difference. So keep that in mind when you're reading the question on the test. What is the question asking me? Okay, what do I have? Does she think? Does she have an abruption going on? But oh yes, it says that she has a board-like abdomen. That's abruption. Okay, that's how you can tell the difference. Just read the question carefully. Okay, so what do you do for nursing care if somebody's having excessive bleeding? Well, also, I'm always going to document my blood loss. I'm going to closely monitor all those vital signs, including I&O. This could be a really good all that apply question, by the way. Observe for pain, uterine rigidity or tenderness. I want to make sure that I know blood typing, and how about cross-matching? Yeah, I'm going to cross-match her for 4 units of packed red blood cells. I'm gonna have my IV going, either with a 16 or 18 gauge angiocath in case I have those big ones in only because I maybe have to give her blood, and you can't put blood through a small catheter. So I'm going to have the big guns. Gonna think of surgery, especially with my abrupt shield placentae. That is an obstacle, obstetrical emergency. Gonna be ready for surgery, so she's gonna be NPO. Always monitor my fetal heart rate. Always, always, always. Okay, because your normal fetal heart rate is between 110 to 160. So I want to make sure that a baby's getting enough oxygen prior to delivery. If she's contracting and she's a placenta previa, probably give her a tocolytic, such as tributaline, sub-Q real quick in order to stop the contractions. And then I'm going to look at her laboratory results. I want to know if she's anemic before we go back to surgery. And I also want to look at coagulation studies. What's her platelets? Does she have low platelets? So that I know how she will take surgery. Okay. Minister oxygen by mask. Usually is about 8 to 10 liters by tight-fitting face mask. And always, 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 you're going to have newborn resuscitation in there. Okay, so last, I think, topic we're going to talk about is going to be hypertension. Preeclampsia is part of, we got hypertension, high blood pressure, and protein in the urine. That's preeclampsia. Now, we go into severe preeclampsia, start affecting the eyes, the kidneys. Not good. We go into eclampsia, and that involves all the organs, also the brain, because it turns from preeclampsia to eclampsia by the patient having a seizure. Okay, once the patient has a seizure, that means the brain is involved, it turns into eclampsia. Okay, not good. Okay, this usually presents about after 20 weeks, not 20 weeks before pregnancy. I got to correct that. So it's after 20 weeks, it shows it, I say, his dirty little face, because it's said that preeclampsia is caused by the spiral arteries in the placenta. They kind of get damaged, and so from probably the hypertension. So therefore, it throws everything off. And she's got spilling protein in the urine, and she could have thrombocytopenia, which is low platelets, so not good. Okay, so it's usually 20 weeks after 20 weeks. All right, just saw that. All righty. Who does it affect? It affects the young kids under 19. So it's your adolescent pregnancies that can get hit with preeclampsia. Women who are having their first baby. Women who already are overweight can have a problem with their blood pressure. Therefore, they could have a problem with, after 20 weeks, having preeclampsia. Family history is important, because did your mom, I always ask them, did your mom have problems with blood pressure during pregnancy? That gives me a clue that maybe she's can be at risk now for preeclampsia. If she's having twins, is the pressure on the body, the blood volume that's going on with the body that can set her up for preeclampsia. If she has already come into your clinic with a hypertension problem, that's called chronic hypertension, you can bet she may have problems with preeclampsia. If they already have a renal disease, coming in with a renal disease, it also can have effect on the blood pressure, and diabetes can have effect. So preeclampsia is never good. So this is what happens. So you have the hypertension, and that's why you have those baseline vital signs. It lets you know that, she's escalating. So if she starts out with 110/70, and she starts increasing to 130/80, the next time she comes in, she's showing now 140/90. Bingo. You can see how it escalates. Then you can also see if she has any edema. Remember, I saw the hands and face were the first ones that you can see that you have problems with preeclampsia. The kidneys, they start to, there's too much circulating protein, so they started screening protein in the urine. Again, that's why you check on every prenatal visit for protein in the urine. Blood clotting, she could be, her blood clotting, especially with HELLP syndrome, they have low platelets, and so they could be a free bleeder. Central nervous system gets involved, especially with eclampsia, with seizure activity. So what's the medication that's given to prevent a seizure in preeclampsia? Guys?
Yeah, I'm here, but it's not
We
coming.
start with an M.
Starts with an M.
Yes.
How about write this down because you're gonna need it. Magnesium sulfate.
Magnesium sulfate.
Magnesium
There's the
sulfate.
calcium.
Right. Now,
It sounds like that's. It sounds like that stuff you give for constipation almost.
Magnesium actually is very good for you. Magnesium is a central nervous system relaxant. So that's why it really good in preeclampsia so that she doesn't have a seizure. So that's why you're giving magnesium. Okay. A lot of students say, oh, it's because of blood pressure. No. It's mainly given to prevent a seizure. Because I have a patient who's preeclamptic. I don't want them to get worse, okay, and have eclampsia. So I want to prevent that brain from being involved. So I'm going to give magnesium to relax the central nervous system. You got it? Yes. So when you're relaxing, this kind of patient would have to be monitored very closely by a nurse. Because when you start relaxing that central nervous system, you're going to affect her respiratory system. Her respirations can decrease. You can also, her reflexes. And that's actually the number one thing I see is that I see an abstinence of reflexes, especially the patella, when I'm giving magnesium. Once I lose those reflexes, I know I got to get a magnesium sulfate toxicity level because she could become toxic. You could give her too much of magnesium. So
then you got to use.
So what would I have at bedside to avoid having problems? What's my antidote?
Calcium.
Yes,
something.
calcium.
Yeah, glutamate.
Yeah, you got it. Good. Okay. Those are two.
With the magnesium sulfate, you would give it to a woman that already has preeclampsia, right?
She's got diagnosed preeclampsia. She's in your hospital, and now in order that she doesn't get any worse, we're going to cut down. We're going to relax that central nervous system so that she doesn't have a seizure.
Gotcha.
Okay, good.
And calcium to just in case you need to bring it down.
Right, because they can get toxic on you. You can give too much, but you can reverse that by giving calcium gluconate. So like when I have a patient with preeclampsia and I'm giving magnesium to, I always have at bedside my calcium gluconate. I took it out of the Pyxis and put it by my bed so that in case that she gets toxic on me very quickly, it does happen very quickly, then I can reverse it quickly. Okay, now preeclampsia can affect her eyes, urinary tract, respiratory system, and GI and liver. With HELLP syndrome, we can write this down, HELLP. The H stands for hemolysis, which is breakdown of red blood cells. The EL stands for elevated liver. And the LP is for your clotting, is low platelets. The patient is very sick. Okay. All righty. So how are we going to manage? Well, how you manage it depends upon the severity of the hypertension and the maturity of the fetus. So the main thing is you want to maintain blood flow to all her vital organs, okay? And therefore, when you do that, you also are circulating blood to the placenta. The fetus needs that. Also, your treatment, again, is preventing her from having a convulsion. So you want to give the magnesium to prevent the convulsion, okay? All righty. So how are you going to do? You're going to have activity restriction. Should probably be in her own private room. Limited activity, limited visitors, because she needs to be in a quiet environment. You want to decrease the stimulation. You are going to always monitor blood pressure. You're going to do daily weights, because remember, edema, you want to make sure she's not gaining a lot of fluid. You're checking her urine for protein, and you're going to give her the magnesium sulfate. And of course, we talked about calcium gluconate as your reverse effects of magnesium sulfate toxicity. And sometimes we do have to give antihypertensives, such as labetalol, which is safe in the pregnancy. Okay, I think we're almost done. Just hang in there. We're going to talk a little bit about bleeding compatibility, okay? We're talking about RH incompatibility. So again, this occurs when you have an RH negative mommy and your fetus is RH positive, okay? All right. Remember, negative doesn't get along with positive, does it? No. So we don't want them to come together. When they do, it can cause the baby to lose its erythrocytes or red blood cells, and therefore the baby gets severely anemic. So what are you going to do? I think, Nicole, you said earlier you're going to give Rogaine. Okay. So this is what we want to, we don't want the baby to get this condition. It's called erythroblastoma fetalis. So you can see here, that right here, so here's your baby. So the baby has RH positive red blood cells. Okay, no problem, right? And so remember, there's always the exchange, but we don't want them to mix, right? So mommy is RH negative. So if you have fetal RH positive, that actually gets into her circulatory system, okay? And remember, it goes through the placenta, but sometimes it does get into her system. Then what her system does is it produces antibodies. And I look at an antibody like a little warrior. You know, he's got a little chisel and he's ready to go after the positive erythrocytes of that fetus. So it recognizes it. So it goes across the placenta, it enters the baby's circulation, and it beats these beautiful red blood cells up. It destroys them. So this now baby has less blood circulating. It gets anemic. When this happens, the baby can get very sick, severely anemic, and it leads to erythroblastoma fetalis. Not good. Now we have done intrauterine transfusions but it's very risky, but we have done it. Usually we do that when we have twins, but it can be done, but again, it's risky. So this is why we want to give mom Rogaine. So we give it about 28 weeks gestation, and then we give it again at 72 hours after delivery to the mom before she goes home. Okay. Now, we want to prevent these antibodies that can cross the placenta and destroy the red blood cells of the fetus. We want to prevent that. By doing so, we give Rogaine. Okay. Now, if a woman has, that test we talked about earlier about amniocentesis, and she's RH negative, she will get a Rogaine shot afterwards. If she has a topic and she's RH negative, she'll get a Rogaine. Of course, I want to protect the next pregnancy, the next baby. That is what you're doing. Because you always want to protect the possibility of maternal blood and fetal blood mixing. Does that make sense? So that's why you give Rogaine.
Got it.
This is always on a test. So
and that's either if the fetus is it could be negative and the mom's positive, or the fetus could be positive and the mom's negative, right?
Yeah, usually there's a problem when mom is RH negative.
Okay.
Don't get that thought out of your head.
Okay, so it's usually mom's RH negative.
Mom is RH negative and the fetus is RH positive. Okay, good. Okay, good. Be sure they always have a question on RH incompatibility. All right. And then we watch, women who are RH negative, we're going to watch a little bit more closely during pregnancy.
Sorry to go off topic.
Yeah, because we don't want, and we watch the baby, make sure the baby's growing. We do the fundal heights to make sure a baby is growing. Okay, good. All righty. The glucose metabolism. And you remember you have your hormones, estrogen and progesterone, cholinase, the enzyme, increased prolactin. They all have effects. What happens is that they increase resistance of cells to insulin. Remember, all your cells, they have the ability to what? Be okay with insulin. But sometimes you have increased resistance of your cells to insulin. And then you have increased speed of insulin breakdown. Remember that HPL I talked about earlier? That also takes place. That can happen. So you have all these different hormones, such as HPL, estrogen, progesterone, insulinase, and even the prolactin. They also have all these effects. So the prolactin you need, it's a hormone that's secreted for lactation, to make milk in the breast. So these are hormones that can increase the resistance of cells to these insulin. So what are you going to do? So she can have periods of hyperglycemia. And because the fetus is continually drawing glucose from the mom, she will also experience hypoglycemia between meals and during the night. That's why you have a little bit of snack before you go to bed, such as maybe a glass of milk or yogurt. It helps to not experience a hypoglycemia in the morning. During the second and third trimester, the fetus is at risk for organ damage from hyperglycemia because fetal tissue has increased tissue resistance to the mother's insulin. So when you're talking about a diabetic and gestational diabetes, we want to make sure that she's eating properly. We watch her weight, make sure we get her maybe to a nutritionist, is because we don't want her to be in a constant state of hyperglycemia.
You want me to put this in a bowl for you for tomorrow?
Okay.
Put this in a bowl for you for tomorrow.
So that's why you have to be very careful with your.
I ain't cook no rice. I got cook rice.
Okay. All right. I think we're coming to an end, Nicole. I know you probably have to get your kids ready for dinner. And then you have these large babies. Let me just put a little something in here for these large babies. These are about 9-pound babies or greater than 4,000 grams. These are called macrosomic babies. Okay, large baby. That's because they were fed too much sugar during the pregnancy. So that's why it's so important to watch mom's sugar. That's why we do those screening tests during pregnancy, about 25 weeks. We're looking at that because that's when the placenta is secreting that HPL. Makes sense. So we're going to do a screening test, and then she fails the screening test. Then she would go on with more diagnostic tests, which would be your glucose tolerance test. Okay, so because you don't want this baby to live in a hyperglycemic environment, because this is what you end up getting. This is called a macrosomic baby. It's a large baby, and you can see this baby has very wide shoulders and a huge head. And this poor baby has looks like also a lot of fluid. But this is a baby that mom wasn't under control during her pregnancy. So he was in a hyperglycemic environment. Now, the main problem that you got to remember, when this baby's born, okay, then his high level sugar is taken away. And so now this baby's blood sugar is going to what? is going to die. He's going to be born, he's going to have a severe case of hypoglycemia. So any babies that have below 45 milligrams per deciliter will be or 40. Some books say 40, so I say 40 to 45 have a problem, and they're sick babies. So this baby is going to go to the NICU. It's going to be on an IV, and his blood sugar is going to be watched very, very closely. So for instance, just say if you were fed a Snicker bar, Snicker bars for 9 months, right? And so you've got a high sugar, right, level in your body, correct? And so now somebody takes away your Snicker bars. What happens to your blood sugar?
It's gonna drop.
It's gonna drop significantly. And so this baby could be very sick. So what's our treatment for a woman with gestational diabetes? Because that's diabetes that's acquired during the gestational time. Is usually we can control a lot of them with diet. If now she's not compliant, then because we're going to monitor blood glucose levels, then we're going to have to get a little more aggressive with it. Usually, if you explain this to the mom, usually you can get some compliance, but every so often they'll go off on, they'll say, I don't want to follow the diet. If they don't follow the diet, they're in a hyperglycemic state, they're going to go on insulin. So not too many women want to go through and go to the perinatologist and then get put on insulin and have to really be monitored. So usually we can get diet, exercise, and monitoring the blood glucose levels will do it. And of course, we're going to monitor her ketones, and we're going to watch the fetal assessment. We're going to watch that baby, because we're going to do what we call NST test.
I know the workout.
A non-stress test, so that we know that the baby is okay. We got fetal well-being. Okay. Once the baby starts showing signs that, hey, this environment in here is not good for me, then we have to think we have to get the baby out. Okay. So this is, again, remember I talked about the hypoglycemic on the baby. Because when they have low blood sugar, they can go into respiratory distress. And that's one of the biggest things about a baby when they're born, is the ability to breathe, right? We talked about that circulation before, and now the cord is cut. So now they have to circulate and breathe, okay? And if they have low blood sugar at the same time, that baby will go into respiratory distress and be a very sick baby. And they also could have injury related to being a big baby. They're delivering this baby vaginally. Can have shoulder dystocia, where the shoulders don't fit through. And mom, they did an episiotomy, and they have her legs wide open. They still can't get the baby out because the baby's head is out, but we can't get the shoulder. Then they're going to have to break the clavicle.
You want a little bit of rice with it?
Pardon? Oh,
Yes.
they're going to have to, that's okay. They're going to have to break the baby's clavicle to get the baby out. So that's another injury related to macrosomia, which is never good. Then we're going to watch this baby blood glucose, and especially their baby probably go to NICU for the first 24 hours at the birth to make sure this baby's able to control and get his blood sugar more up, okay, and increase. And of course, breastfeeding is always good. All right. I talked about heart before. We talked about the risk of arthropathy, and we talked about congestive heart failure because of the increased amount of blood being circulated through the mom's body system. This is just signs of CHF. And just like any other med-surg patient, when you have somebody who's in congestive heart failure, they're going to have persistent cough. Listen to this lung sounds, and you can hear it's going to be moist. They're definitely going to have difficulty breathing. Same thing as in medicine. You can, with CHF, it can occur in pregnancy. The main thing you have to add to everything here is the changes in the fetal heart rate. You can have hypoxia, or baby doesn't grow you can have a growth restricted baby. So is, having a heart problem during pregnancy puts the mother really at big risk because of the increase in the cardiac output. Okay. So this lady will be under the guidance of an obstetrician and a cardiologist. She would have limited physical activity. She'd probably be on anticoagulants and a diuretic. And again, vaginal birth is preferred because vaginal birth has less risk for infection or respiratory complication than a C-section. Okay. All right, I think we pretty well got it. This, we talked about anemia before. It can decrease. Remember, mom needs blood to carry oxygen to the cells. Okay. If she's iron deficient, we're going to give her iron supplements. Okay. What do you tell the patients taking iron? What should they drink to swallow an iron tablet?
Orange juice.
Orange
Orange
juice.
juice. Good. What should they avoid if they're on iron?
Yeah.
Coffee.
Yeah, tea.
What's the big one? Especially if they have heartburn.
Milk.
Yeah. Antacids.
Yeah, that's right. And
That's
milk,
right.
I think.
Good. If they're having anemia due to nutrition problems, these are your symptoms that can happen. This is really pretty bad. I mean, they get fatigued. You're not eating right. Mucous membranes are pale, shortness of breath, rapid pulse with severe anemia. Okay, and then torch. These are infections, guys, that can occur. You want to avoid. So toxoplasmosis. A woman
That's
can
cat
get
feces.
That's right. Cat feces, great. And what else? Raw meat.
Toxmosis. Oh, raw meat. Yes, like
Raw meat.
like sandwich meat. Yeah, I didn't think about sandwich meat.
Yeah, you can get toxoplasmosis. These now, toxoplasmosis, rubella, cytomegalovirus, and herpes, they are all bad for a baby. They all can cause congenital defects. They can all, like hearing loss, abnormal clotting in the baby. These are never good, okay? So you can look at the acronym TORCH. So the other is just other viruses. Rubella, we talked about rubella already. Cytomegalovirus is a common virus in the same family as the herpes, okay? It's spread by direct contact of body fluids. And then you have your herpes virus. So that's your TORCH. That's like a little thing to help you basically remember. All these infections such as syphilis, gonorrhea, chlamydia, trichomonas, venereal warts, they're all transported infections. They're all transmitted. Never good. Okay. And so these, go ahead.
Does that mean that the mother would have a C-section?
Yes, especially if you have somebody who has herpes and they have active lesions, they have to have a C-section. You don't want them coming through a vagina with chlamydia, or gonorrhea or syphilis. This is why in that very beginning of pregnancy, we do screening. We will do vaginal cultures. Okay, and I have come across where I had to give penicillin injections to women who were positive for gonorrhea. Yeah, and so they have to be on alert. Group beta strep is another bad infection that can affect the neonate. Okay, the neonate comes through. Let me see. I think I have one from that. Let me say. Okay. Group beta strep can cause respiratory distress in a neonate. All right, real quick, HIV. The infant can be infected. If mom is HIV positive, then it is transmitted to the baby through the placenta. So mom, it gets started on antiviral medications. It should probably come to you being on them. And then when the baby's born, he'll also get antiviral. The main thing I want you to remember is that it also this virus can be transmitted through the breast milk. So infants have to be in the NICU, being very well monitored, and so they can be in the room with mom, but they can't. Mom cannot breastfeed. Okay, all right. I think you probably we went through this already. This is your toxoplasmosis, which is your we went through that. And you see all these different signs, possible signs: low birth weight, large liver and spleen, jaundice, anemia, eye structures, neurological damage. That's what happens with all these different viruses, really. Okay, so this is another one. You probably will see this on the next exam. They always like to put a question about group beta strep, okay, or GBS infection. Where it lies is in the woman's rectum, in the vagina, okay. That's where we kind of focus on when we're culturing for GBS in pregnancy, is right here. About 36, 37 weeks, we'll test every single woman to see if she's got it, because she's asymptomatic, okay. They don't realize they have it. If they come through a vagina that's infected with GPS, we can give mom during labor antibiotics, okay, and that will help. If we didn't know that she had GBS and the baby came to the vagina, the baby's at risk for respiratory distress. And this is where we lost years ago, guys. This is really true. We lost a lot of babies due to respiratory distress or hyaline membrane disease because we didn't know she was positive for GBS, because when I started maternity, we were not culturing every woman. You got it? So over the years, and I did my thesis on this, is basically we changed this around and we got every woman to be cultured. Okay, so by doing that, we saved a lot of babies. And that's why, because they can be deadly to the infant. All right. And then we already talked.
There's no vaccine for the group beta strep.
No, but it's easily picked up. You have a very bad sore throat. They're looking at, in your throat, are they not? Yeah. In maternity, we look at the rectum and the vagina, because that's where it's the organism is found. It's found in the woman's rectum and vagina. So we'll culture every woman, usually about 36, 37 weeks gestation. Every woman gets done. Even if you've got an induction going on, and say you're going to have this lady come in for an induction, the pediatrician will now not allow the induction to go on if we don't have a GBS culture on the chart. We have to know the status of every woman before she delivers.
Got
and
it.
It's easily taken care of. We give the antibiotic while she's in labor through the
Okay.
IV. Yeah, and we can take care of it. So it was a big thing when this was discovered.
Okay.
I remember when it was discovered. So I'm pretty excited about it, but still we saved a lot of babies by recognizing that this was a definite problem with a high mortality rate in the perinatal environment. Okay, now the next area we talked a lot about urinary tract infections. We know that your bladder doesn't get empty completely. She can get cystitis, you have burning with urination, increased frequency and urgency, and they can have a little temperature, but it really gets bad, and it can put her into preterm labor. We don't want that to happen. That's why every woman is tested every time she comes into the clinic. She will have a urinary, little bottle. Give me a sample. I want to see if you got any WBCs in your urine or nitrates. Okay. Again, you don't want a woman to have a UTI and go into preterm labor, because you don't want to lose a baby. So we want to get on top of it. if you don't recognize this, or she doesn't, if she has more than a cystitis, it can go up in the kidneys, and
You
then
eat all the cake?
then you have polynephritis. Okay.
So basically, a UTI can cause a woman to have the baby too early.
Yeah.
That's the major risk of a UTI,
Yes.
you think?
Yeah. Yeah. Plus, it's very uncomfortable for her.
Yeah.
Yeah. I mean, she's sick. I mean, she can have a temperature.
Yeah.
And you feel like you got to go to the bathroom, you can't. You sit on the toilet and try, and
Yeah.
then you get up again, and then don't forget she's got a pregnant belly. She's got to go to the bathroom, and then she sits on the toilet. She can't go. It's horrible. And then when you
Miserable, yeah.
urinate, you got this burning. It's very, very uncomfortable. And
Yeah.
then it gets worse. It goes up in the kidney. So then you have the flank pain or tenderness in the kidney area in the back. You have to test for that. And now you got a problem. And yes, Alan, you are absolutely correct. She can go into the main problem is preterm labor. Absolutely. You got it. Okay. I just had this slide on the environment. We kind of talked about substance abuse already. We talked about alcohol. And don't forget, a single episode of consuming 2 alcoholic drinks can lead to loss of fetal brain cells. And so you don't want your pregnant lady to be drinking alcohol or using any kind of substance, because everything is transplacental, go right across the placenta to the fetus.
Yeah.
The fetus will. Go ahead.
You said everything except for for the diabetics, not the insulin.
Yeah, because insulin is a large molecule. Okay, so
Yeah.
that doesn't cross the placenta, but everything else.
Everything except for insulin.
Right.
So anything you put in that woman's body is going to the baby. Good,
That's
bad,
right.
ugly.
That's
Yeah.
right. You got it. You got it. Now we talked about trauma, and if she gets a hit in the stomach, that can cause you to have an abruption. So can also cause traumatic death. So automobile accidents, homicides, suicides, battering. You want to be monitoring for intimate partner violence. So if we just remember too, that if a woman confides that she's being abused during pregnancy, you have to keep that absolutely confidential. Because she's trusting you, but if her life's in danger and her abuser learns that she has told anyone, she's in danger. And get this, she could, it's up to her to make the decision as to if she wants to be referred to a local shelter. You can, help her, but the decision to leave her abuser is hers alone. And guys, I commend you guys, because there's my rose to you. We conquered chapters 2, 3, 4, and 5.
Yes, we did.
How do you feel?
Dinner. I cooked dinner. I had company at dinner cooking.
Well, thank you so much,
Thank
Professor
you.
Dunham, for your
Yeah.
time.
Oh, you're
Thank you.
welcome. And I want you to do good. Okay.
Thank you.
Yeah.
Appreciate
You're
it.
welcome. Okay.
Have
See
a
ya.
good evening.
You
Bye-bye.
too. Bye. Oh, I look tired. All right.